Good morning, students. Assalamu alaikum, and welcome to your ophthalmology clerkship video sessions. I will be your host today, and we will begin by just having a bird's eye overview of how we are going to do things. In ophthalmology, we group all of our diseases into patient presentations because, after all, that is what you are going to be doing once you graduate, seeing patients. And our curriculum is organized into themes, and each theme is a specific type of patient presentation. The first theme that we start off with is gradual painless loss of vision, and most of the patients that you see in the ophthalmology clinic are going to fit into this type of a presentation. So we'll do all the diseases that fit into this theme, and once we are done with them, we will sort of review them in a tabular form so that we can sort of try and differentiate between those based on their history, presentation, and basic examination skills, something that you can do sitting in your clinic as a family physician or as a graduate doctor. The competencies that have been identified for the ophthalmology curriculum are those that fit the profile of a family physician. We are not going to make you ophthalmologist. We are not training you to do that. That is a post-graduation domain. We are just making you competent enough so that you can pick up basic eye diseases that you can either manage on your own or recognize and realize that this needs a specialist referral not only to an ophthalmologist but to any other specialty as is required. And you will see as we move along the clerkship, we will be talking about other specialties, well, endocrinologist, nephrologist, internist, neurosurgeons, neurologists. As the need arises, we need to take help. After all, we are a team that consists of not only doctors, paramedic, nurses, but many, many more people whose faces we don't see at many times, including engineers, etc. So why we do this is because we have to see patients all day, and doing things this way makes differentiating between diseases simpler because it's based on what your patients present with. And if you can differentiate between diseases better, you can come up with a diagnosis in a much more rational and an easier way. We're going to start off our discussion of ophthalmology with refractive errors, which is one of the most common presentations in an ophthalmology clinic and is also the first differential of our gradual painless loss of vision theme. And this is what we are going to be discussing today. Seems like a lot, but it's not, because some of what we are going to discuss you've already done in school in the form of optics, and some of you might also be wearing spectacles or glasses, so you know the basics of refractive errors, and you did refractive errors in special senses. And you might also have people in your house who are wearing near vision glasses, so you should have a very good idea of what refractive errors and what to do with them. There are only a few things that you really need to pay attention to, otherwise this is going to be a breeze. So we're going to start off by talking about a little bit of optics, and we're going to talk about refraction of light and also a little bit about lenses. So refraction is a phenomena that occurs when light is traveling from one medium to another. And we have all done this glass block experiment in which we have an incident ray or an object ray that meets another medium, in this case a glass block, and it changes its direction, i.e. it refracts. And this is called the refracted ray. And when it exits the medium, it's called the emergent ray or an image ray. Usually we use the term incident and emergent, but you can also use object and image rays depending upon what sort of an experiment you are doing. Both of these terminologies are correct. And this process right here at the change of the medium is called refraction, and refraction occurs because of a difference in refractive index of the medium. Refractive index is denoted by n, and the greater the difference between the refractive index of the medium, the greater the bending or refraction of light. Now, the refractive index depends upon a lot of things, and the two things that are really important to us is the optical density of the medium and the thickness of the medium. Optical density is the ability of a medium to change the direction of the light, and the thickness of the medium is simply that, the thickness. So if two mediums have equal thickness but different optical densities, they are obviously going to refract light differently. The medium with a greater optical density would refract light more as compared to the medium with lesser optical density, which would refract light less. So before we go on and talk about lenses, there are certain basic principles that we need to go over. The first is that any light rays that are coming to you from infinity, sun, galaxies, other stars, are traveling parallel to one another. In ophthalmology, a distance of 6 meters or more is considered as infinity. The reason it is considered as infinity is that the light rays from 6 meters or beyond can be considered to be traveling nearly parallel to one another. They're not exactly parallel, but nearly parallel. Good enough so that we can, do our ophthalmology work. So distances of 6 meters or more in ophthalmology is considered to be infinite, and light rays from 6 meters or more are considered to be traveling parallel to one another. That is why you have the Snell's chart at 6 meters. 6 meters equals 20 feet if you are still following that type of system. Any light ray that is coming from less than 6 meters is going to be diverging in nature. These are called near light rays, and they are diverging from one another. And these are the ones that are coming from cell phones, books, laptops, which are obviously at a distance of 6 meters or less. And I usually are, especially cell phones and books, ideally. Unless you just keep a cell phone at a distance so everybody thinks you're using a cell phone to, take one of those Zoom medical college classes, but you're not, because the headphones are, pointing to a different station. And most these distances are measured in meters because we follow the metric system of weights and measures. We're going to start off by talking about a very specific type of lens. That's a spherical lens, and a spherical lens is a lens that brings all light passing through it to a point focus. It doesn't matter if the light is passing through the vertical or the horizontal meridian or the axis of the lens, it is just brought onto a point focus. And they are generally of two types, the convex and the concave lens. A convex spherical lens is one that is going to bring all parallel light rays or incident light rays to a point focus. It is going to converge them. The first 5 letters of convex and converge are the same. So that's one way of remembering what a convex lens is. Convex lens of different thicknesses would obviously refract light differently. A thicker lens would refract light more, and also a lens of greater optical density but a similar thickness to a lens of, as compared to a lens of lesser optical density, would also converge light more. And if you have a thicker lens, obviously it is going to converge light more. But the thing to remember is, if you have two lenses which are of equal thickness but different optical densities, the lens with the greater optical density would converge light more, and it goes without saying that the thicker lens would obviously converge light more as compared to a thinner lens. So convex lenses converge light. Convex and converge have first 5 letters in common. Increased thickness and or increased optical density would increase convergence. A concave lens, as opposed to a convex lens, diverges light. And whatever image is formed by extending the light rays backwards, because these diverging light rays are never going to meet each other, and they form a virtual image. The nature of the image is really not much of a concern to an ophthalmologist. We just need to know if it is converging or diverging light. And again, if you have a lens of equal thickness but of a greater optical density, then this would obviously be diverging light more. Remember, this is a diverging lens. And if you have a thicker lens, obviously it would diverge light more as compared to a thinner lens. So concave lenses diverge light. Greater the thickness and or greater the optical density, the greater their ability to diverge light, or divergence. Unfortunately, concave and diverge don't really have much in common, but convex and converge do. So you can please remember one of them and apply the other rule to the other lens, i.e. that convex lenses converge, so the concave must diverge. It's the rule of exclusion. If you forget, you shouldn't be. It's really simple. Now we are going to talk about, we talked about convergence and divergence. We are going to learn how to quantify this convergence and divergence, and we are also going to learn how to calculate light rays and lens interactions, what happens when light rays meet lenses. So a diopter is the unit which quantifies this convergence and divergence. And it can be for lenses, and it can also be for light rays. And it is symbolized by the capital D. For light rays, remember, light rays could be converging and diverging. We talked about two types of light rays, parallel light rays and diverging light rays, just a few moments ago. So parallel light rays are those which are neither converging or diverging, so they have no power. Zero power. And diverging light rays, since they are moving further apart from one another, they have minus power. Converging light rays, because they are moving together with one another, they have positive or plus power. But how do we measure this power? Simply by inversing the distance that these light rays have traveled. And the inverser, or the thing that we put on the top of our equation, the numerator, is going to be the refractive index of the medium. And since most of the time we are surrounded by air, thank God for that, and air has a refractive index of 1, so it's simply inversing the distance that these light rays have traveled, and obviously we are measuring these things in meters. We'll do a little bit of a thing or a question to elucidate all of this. Now, diopter is also a method of quantifying power of lenses. For convex lenses, the power is in plus. For concave lenses, the power is in minus. Simply because convex lenses converge light, and converging light rays have positive power, so these light rays must be giving positive power. And since diverging light rays have minus power, concave lenses diverge light, they have minus power. So another way of thinking about a power of a lens is the amount of power that a lens can add or remove from light rays. So a convex lens is going to add power to light rays, a concave lens is going to remove power from light rays. So we'll just do this little question to explain all of this. So you have this little nice scenery, and this scenery is 2 meters from a +3 diopter lens. Now, what we want to do right now is to figure out where would be the image formed. If this is the picture, this is the lens, and this is the distance. And to calculate this, what you need to do, you need to add the power of your light rays to the power of lens. Remember, lenses are just adding or removing power from light rays. So the first thing we need to do is to figure out the power of light rays, and then we add this number +3, which is the power of lens, to the power of light rays. So, but we don't have the power of these light rays, we just have a distance. But we know the formula for converting distances into light ray power. And if you remember from the previous slide, it's simply a matter of inversing the distance, and the distance is measured in meters. So if this is 2 meters, we inverse 2 and we come up with 0.5. And since these are diverging light rays, we put a minus sign. Why are these diverging? Well, because they are coming from a distance of less than 6 meters. And remember, any light ray coming from a distance of 6 meters, less than 6 meters, are diverging. We've also talked about this, because 6 meters or more is considered to be infinity, and then the light rays become parallel. Less than 6 meters, all light rays are going to be diverging, and this is just 2 meters. So this picture, which is 2 meters away from this lens, the light rays coming from this picture would have a power of minus 0.5 diopters when they get to this lens. And now we simply add the two up. So minus 0.5 plus 3 is 2.5 diopters, and a plus because this is algebraic addition. So the light rays that are going to get out of this lens, the emergent light rays or the image light rays, would have a power of 2.5 diopters. But this is not giving us the distance at which the image is formed. But we know the formula, and the formula is the one that we did before, that the power is inverse of distance. This time we have the power, so all we do is we inverse it and we get the distance. But right now, the most important thing for us to remember is that to calculate the interaction between the light rays and lenses is simply to algebraically add up the power of light rays to the power of lenses. Not all the time you will have power of light rays given, but you would have the distance. So you inverse the distance, you add it to the power of the light rays, and you'll know where the nature of the emergent light rays or the image light rays. And if you want to know where this light rays would focus, you just inverse this 2.5, and then you will get that answer. But that's not really important for us. What is important for us is to be able to learn that to calculate light rays lens interactions, we add the power of incident light rays or the object light rays to the power of the lens. Not all the time you would have the power of incident light rays, so you just inverse the distance of the light rays have traveled to reach the lens, and that will give you the power. We'll do some more questions and it'll become clearer as we go along in our discussion. Now we're going to be talking about optics of the eye, which is the first thing that is remotely related to eye in this discussion. The first thing that we need to talk about when we talk about the optics of the eye is the concept of the reduced eye. And the reduced eye concept is really not that difficult. What it does is it considers eye to be a singular refractive surface of a fixed power, which is about 60 diopters, and of a fixed length, which is about 22.6 millimeters. And if you see this figure here, we have four surfaces, and all of these are transparent, and they are transparent because they allow light to pass from the outside here all the way to the retina, which converts light energy into electrical signals, which can be interpreted by the visual cortex. Rather than considering these surfaces as individual refractive surfaces, reduced eye merges them into one and gives it a power of 60 diopters. The majority of this power is coming from the cornea, and the next major contributor is the lens. But if you look at the picture, the cornea is thinner than the lens, which really should be contributing less power, not more. The reason it contributes more power is because of the difference in refractive indices of the medium. Cornea is surrounded by air, which is a refractive index of 1. Cornea has a refractive index of 1.38. The aqueous humor has a very similar refractive index to the cornea, so we'll just consider it as 1.38. The lens has a refractive index of 1.4. So the difference between the refractive index of aqueous humor and the lens is just 0.02, whereas the difference between the refractive index of air and cornea is 0.38. Thus, the more refraction occurs at the air cornea interface as compared to aqueous humor lens interface. Thus, cornea provides the majority of this power. The length of the reduced eye is 22.6 millimeters. However, a normal individual might have an eyeball in the range of 22 to 24 millimeters, while at birth the length of the eyeball is 17 millimeters. If you think about it, since we are saying that the eye has a power of 60 diopters, and this 60 diopters is able to take light rays which are parallel, we'll talk about this in a minute and focuses on the retina. If your eyeball length is not 22.6 and falls within this range, this 60 diopter power has to be different. If your eyeball is shorter, the light rays have to be refracted more, so this power would be slightly more. If your eyeball is longer, the light rays have to be refracted slightly less, so this power might be less as long as the range is within the normal limit, and the light rays have to focus on the retina. We'll come back to this in a little bit of time. So how is the image formed on the retina? We've just talked about the power and the length of the reduced eye. So this is the picture of the retina. It's actually the picture of the posterior pole. We'll talk about what the posterior pole in just a bit. What you see here are certain important landmarks. This is the optic disc. This is the structure through which all the neurons, the nerve fibers, exit the eye to take the signal all the way back to the visual cortex. Obviously, there is going to be a change of neurons somewhere down the line. This is the fovea. The fovea is the part of the eye which has the maximum density of cones and provides the best vision in terms of the resolution of vision, resolution being the resolving power of the eye. And this has a little white reflex right here. We'll just see why this white reflex is produced and how it is produced. The area around the fovea is called the macula, and the macula is the part of the retina that is between the two major divisions of the central retinal artery, which is shown by these white arrows. The macula has the next highest density of the cone photoreceptors, not as high as the fovea, but the next highest density. The area outside the macula is called the extramacular area, and this is beyond the boundary of the macula to the boundary of the retina, and this is almost exclusively populated by rods. And posterior pole, as I said, is the optic disc together with the macula and the fovea. Well, if you're considering the macula, you already consider the fovea because the fovea is the center of the macula, right here, shown by the yellow circle. So the optic disc together with the macula is also referred to as the posterior pole. So this bit plus this bit together is the posterior pole of the eye. So when we talk about where on this retina is the light focused, well, obviously the light is going to fall on all of the retina, but not all of the retina provides or produces similar clarity in vision. And I'll show you by this diagram. This is your fovea, and this black circle represents your macula, and these are three friends who are sitting on a sofa. And what is going to happen is light rays of your object of interest, the person or the thing that you want to look at, your eyes are always pointing towards that. The motor cortex tells your eyes to point where you want to look, or where the motor cortex wants you to look. So if you want to look at the person sitting in the middle, your motor cortex is going to tell the extraocular muscles move so that this person is right in front of you. Your eyes are directed at this person. And the light rays from this person are then going to focus on the fovea. This is also called the visual axis, where the light rays from the object of interest are going to travel all the way through to the eye onto the retina. So there are other people who are sitting right next to this person, so that the light rays are also from these people going to fall on the retina, but they're not going to fall on the fovea. Only the light rays from your object of interest are going to fall on the fovea. So these individuals, so these light rays are going to fall right here onto the fovea. And the reason that the fovea is able to generate such good detail is because its thickness is less. It's not 10 layers, it's actually less than 10 layers, because most of the layers, retina has 10 layers, by the way. Most of the layers move to the side so that the light rays can pass through the minimal thickness all the way to the cone photoreceptors, which has the greatest, this area, the foveal area, has the greatest resolution or the greatest visual acuity, because it has the shortest pathway to the for the light rays to reach the photoreceptors, thus producing the best clarity in vision, the most resolving power. And that is why when you do Snell's visual acuity, and I'm sure you have done it, the Snell's chart is kept at 6 meters so that light rays can be considered to be parallel. And these light rays are parallel because these three friends are sitting at a distance of 6 meters from this person, which you can consider to be yourself. The reason you keep the Snell's chart at 6 meters so that light rays can be parallel. And these light rays would then focus on the fovea. Why is it important to keep it as parallel? That is just going to come up, but I'll just say that the eye with 60 diopters of power and 22.6 millimeters of length is able to focus parallel light rays onto the retina without doing anything else. Thus, 6 meters is the distance you keep the Snell's chart so that you can know whether your eye is able to focus that light on the retina or not. And you know that because a normal person can read the 6 meter line sitting at 6 meters, i.e. 6/6 vision. We have an entire clinical skills on visual acuity. You can refer to that for more information as to how that happens. But right now, things that you want to see are right in front of you. By the motor cortex commands your eye to do that. And the light rays from that object focus on the fovea, and the fovea provides the greatest visual details simply because the light rays have to travel through the minimal thickness of the retina because most of the layers move to the side, and fovea has the maximal density of cones, which provide the best resolution. But what about these individuals? So let's see, light rays from this person is going to fall within the macular area, but not on the fovea. So the details from this person are not going to be that clear. You'll know that there's somebody sitting there, but you'll not be able to make out their facial features as well as the person who is right in front of you. And the same goes for the other person on to the right of this person that you want to see. The light rays from that person are falling outside of the macular area onto the extramacular area. So this person is going to be even blurrier because here you mostly have rods, you don't have many cones. So the reason I'm showing you this picture is that when you want to check the function of the fovea, you do visual acuity. But when you want to check the function of the rest of the retina, you do something called a visual field. The visual acuity is only checking the function of the fovea, while visual field is checking the function of the rest of the retina, usually not the fovea, because the fovea is checked by doing visual acuity. So this bit right here is tested by doing visual acuity, and that one of those methods is Snell's chart or Snell's visual acuity. And light rays, when we talk about refractive errors, which we're going to talk about just in a bit, we are only considering light rays that focus on the fovea. Obviously, light rays focus everywhere, but if they're focusing on the fovea, they're going to focus everywhere on the retina. But specifically, our discussion is going to be about these light rays because these are the light rays that generate the visual acuity, the resolving power of the eye. Resolving power of the eye is just to make out detail. Again, refer to the visual acuity clinical skills for more information about visual acuity. Visual field, as I just said, is the total visible area to a person, and that would include the foveal, macular, and extramacular area. The visual field, the macular area and the extramacular area are obviously tested using visual field testing. There are a variety of methods. We'll talk about them when we talk about open angle glaucoma. But in summary, again, visual acuity is a function of the fovea, and it is tested using Snell's visual acuity. Visual field is everything you can see, including the fovea. Visual field testing is done using various ways. I'm sure you have done confrontation visual fields. But when you're doing visual field testing, usually the fovea is not tested because it's already tested using visual acuity. So let's consider, once we are done with that, how does a normal eye focus distant light rays as well as near light rays. We'll talk about distant light rays first, then we'll talk about near light rays. The word that we use to describe a person who is able to see clearly for distance and appropriately for distance is emmetropia, given right here. So let's see what emmetropia is. And remember, when we talk about distant vision, we are talking about light rays that are parallel, because when we talk about distance, we are talking about distances of 6 meters or more. So light rays are parallel, and parallel light rays have no power. These are coming from a distance of 6 meters and more, and the eye takes its 60 diopters of power and it focuses those light rays onto the retina. And we have done that a reduced eye has 60 diopters of power and 22.6 millimeters of length, and taking these into account, parallel light rays are focused onto the retina by the 60 diopters of eye power. So in other ways, if we were to put this into an equation, power of object light rays or incident light rays plus the power of lens gives us the power of emergent light rays or image light rays. So power of distant light rays is 0, power of eye is 60, and it's plus 60 because it's a converging medium. So 0 plus 60 is 60 diopters. The emergent light rays with 60 diopters power focus on the retina when the length of the eyeball is 22.6 millimeters. This is emmetropia, M meaning equal, metrop meaning measure, opia meaning eye or vision, equal measure of vision. And I've already talked about this. Not all eyeballs are going to be 22.6 millimeters in length. The range is between 22 and 24. And all of these individuals can be emmetropic because since the 22 to 24 is normal, right? So if your eyeball is 24, it is still within normal limits. But for an eye that is longer, you wouldn't need so much power. You actually need a little bit less power because your eyeball is longer so that the light rays can travel a little more. For example, if your eyeball was 24, the retina would be here. And if your power was 60, they're already focused here. So you'd need less convergence. So your eyeball power would be less. So since not all the eyes would exactly have this length, not all of them would have 60 diopters of power, there's going to be some variation between power depending upon what the length is so that the light are still focused on the retina. Depending, everything is still within the normal limits, which is 22 to 24 millimeters. A refractive error is going to occur when the power of length do not match to focus the light on the retina. And we'll see how that happens just in a bit, I promise. But this is for distant vision. Let's see what happens for near vision. So what happens is that when you're looking for near, the light rays are going to be diverging and will have a certain amount of power, and your eyes will have to compensate for that power, and it does it by producing something called an accommodation reflex or a near reflex. And this accommodation or a near reflex takes place when you are looking for something that is closer to you, closer than 6 meters. And the changes that take place in an accommodation reflex or a near reflex are 3: accommodation, pupillary constriction, and eyes moving close together or converging. All of these 3 are called the accommodation reflex or the near reflex. Now, the confusing thing is that the accommodation reflex or the near reflex has something called accommodation within it. So a component of accommodation reflex is accommodation. Sort of confusing, isn't it? But it is what it is. And near reflex and accommodative reflex are terminologies that can be used interchangeably with one another. I'll show you a little video as to how all of these changes occur and why they occur. Then we'll do some questions again, or we'll do a little bit of a practical to demonstrate what we have talked about so far.
First, as an object approaches, both eyes track it in a process called convergence. The size of the eyes in this example has been greatly exaggerated so that the subtle movement that takes place during convergence can be seen. Convergence of the eyes keeps the image of the object of interest centered on the fovea, the part of the retina where resolution is highest. If the eyes do not converge appropriately, diplopia, or double vision occurs. Second, the pupil must constrict to restrict the entry of light rays diverging from a near object, since diverging rays cannot be bent enough by the periphery of the lens to make them fall on the fovea. If the pupil were to remain dilated, the image would be blurred. Finally, the shape of the lens must change, increasing its refractive index so that the light rays passing through it converge on the fovea. In distance vision, the lens is pulled at its equator by the suspensory ligament, so that it is relatively thin. When the muscles of the ciliary body contract, the tension on the suspensory ligament decreases, and this allows the lens to assume a rounder shape, increasing its power to bend light. As a result, the image is focused on the fovea. Combined, convergence, pupillary constriction, and rounding up of the lens all function to keep an object in focus as it approaches the eye.
Okay, so that is what the accommodation of the near reflex is, of which the most important bit is accommodation, increasing the power of the lens. Why do we need to increase the power of the lens? Because the light rays coming from near are divergent. So what is happening is you have, for example, light rays coming from your cell phone that is lying at 0.25 meters. And if you remember from the question that we just did, in which we have that nice painting, and which was, the light rays from the painting were approaching a lens. So this time what is happening is you have, or a scenery, not a painting, or whatever it might, whatever takes your fancy. Anyway, so this time you have your cell phone, which is at a distance of 0.25 meters from your eye, so something like this. And the light rays, when they reach your eye, would have a power of -4 diopters. I know this because I can simply inverse the distance, which we've done the formula before, which gives us the power. And this is a minus power since the light rays are divergent. And normally the eye has 60 diopters of power. And we have already seen that what we need to do is add the power of the object or the incident rays to the power of the eye, which will give us the power of the emergent rays, which in this case is going to be 56, because -4 plus 60 is 56. And we need 60 diopters to focus the light on the retina. And we don't have 60, we only have 56. So these light rays are going to converge less, because 56 is less than 60, and they focus behind the retina. And this image is going to be blurry. And that is where accommodation comes in, which makes this lens thicker so it can increase its power. And the stimulus for the accommodation to initiate is a blurry image. Anytime you have a blurry image on the retina, the process of accommodation would be initiated. It's an autonomic involuntary reflex. It's involuntary, it's not under your control, and it's under the control of the autonomic nervous system, which is by and large or almost exclusively autonomic in nature. That is why it is called the autonomic nervous system. And the ciliary muscles contract in response to the parasympathetic innervation from the ciliary ganglion. So it is driven by the parasympathetic system. It's stimulated by the parasympathetic system, which contracts the ciliary muscles, which releases the tension on the zonules, which makes the lens more curved, And obviously, you will have near objects lying at varying distances. So it only needs to increase its power enough so that light rays coming from that object are focused, which in this case would be taking the power of the eye from 60 to 64, so that we can neutralize this -4. But remember, of this 60, the lens contributes 18. So actually the lens is raising its power from 18 to 22 diopters. Thus the eye goes to 64 diopters. So -4 plus 64 equals 60D, and the light rays would now focus on the retina. So in order to focus near light rays, the eye must accommodate so that it can increase its power. And how that happens is by contraction of the ciliary muscles. So this picture shows a cross section of the eye. This is the ciliary body, this is the iris, and these are the zonules that are holding the lens in place. So when you have an unaccommodated eye, which is focusing for distance, the ciliary muscles are relaxed. And when you contract the ciliary muscle, the zonules relax, and the lens can become more globular than before. So this is what's happened. Unaccommodated eye, ciliary muscles are relaxed. The lens is, nice and thin because the zonules are stretched. When you have ciliary muscles contracted, the zonules relax, so the lens can become more globular. And this is how accommodation happens. And accommodation is a part of the accommodation reflex, as we've done before. But we've also talked about that you only need to increase the power of the eye to get the image into focus, and not all near objects are going to be at the same distance. This person likes to use his cell phone from 0.33 meters, and the light rays reaching the eye would have a power of -3, and an unaccommodated eye would have a power of 60, and these light rays would have a power of 57, and they will again focus behind the retina. If you are confused as to why 57, just go one slide back and just review it. So this time the lens only needs to increase its power to 63 and not to 64, because it only needs to neutralize -3. So the amount that the eye has to increase its power by is called the amplitude of accommodation, and it would vary depending upon where that near object is. In the previous example right here, we needed to increase the power of the eye by 4 diopters. So the amplitude of accommodation here was 4, because that's the power that the lens was able to increase the power of the eye beyond 60 diopters. In this case, the amplitude of accommodation is only 3, because we only needed to raise the power of the eye by 3 diopters. What is going to be the amplitude of accommodation in this case? It's very simple. You don't even need to do math. Just take this number and change the sign, because -5 plus 60 is 55, and we need 60. So 55 plus 5 is 60. We just need to neutralize the power of incoming light rays. So the amplitude of accommodation is going to be equal to the power of the incoming light rays. Here we go. See, I wasn't lying to you. So again, I'm giving you these various examples because the amplitude of accommodation would vary depending upon where that near object is. Usually the normal reading distance is considered to be about 25 centimeters. In some parts of the world it's 30, in some parts of the world it's 40, but usually here we consider normal reading distance of about 25 centimeters. So as the accommodative amplitude is dependent upon contraction of the ciliary muscle, and accommodative amplitude is required to see for near, and the amount of accommodative amplitude required equals to the distance of the near object. All of this is going to suffer as you age, because amplitude of accommodation decreases with increasing age because your ciliary muscle weakens. And as your ciliary muscles weaken, your eye will not be able to converge as much as it was converging before, and there will come a time when you will not have enough accommodative amplitude to see clearly for near, and we'll get back to that in a bit, and then you will have trouble reading for near without any added assistance. I'm showing you this chart which shows you age together with the number of eyes tested and the amplitude of accommodation. And as you can see, when you are born or when you're very young, you have a lot of amplitude of accommodation. This mean amplitude in diopters is amplitude of accommodation. By the time you're about 35 or close to 40 years of age, it falls to 3.3. And there is a reason there's a blue box around this, and we'll just see why that is in a bit. So let's recap what we have done. Light rays coming from infinity, a distance of 6 meters or more, are considered to be parallel. Parallel light rays have no power and are focused by a resting eye, an eye that does not need accommodation, onto the retina, which is called emmetropia, equal measure of vision. Light rays coming from near or a finite distance, which is 6 meters, less than 6 meters, produce a blur image on this retina, and this blur forces the eye to accommodate. It forces because it's an autonomic response. Accommodation involves constriction of ciliary muscles, which makes the lens thicker. Remember, accommodation reflex is accommodation plus pupillary constriction plus convergence, but accommodation by itself is just increasing the thickness of the lens to increase its power. Accommodated lens is able to focus the light rays back on the retina. The amount of accommodation depends upon where is the near object, i.e. how far is it from the eye. The most important message right now that I want you to pick up is a blur image forces the eye to accommodate. And the eye will always try to focus a blurred image on the retina because it's an involuntary autonomic reflex. Autonomic reflexes are involuntary. I'm sure you know that. And remembering this will help to clear a lot of confusion. Remember, these are very easy things, but there is only a couple of things that are important, of which one is remembering this. Everything else, I'm sure that we have done so far, you already knew. Even if you didn't know, you already knew it, because we have done all of these things before, either in school or in special senses. I'm sure you did special senses, paid very special attention to it, because those are really special senses. That's why they're called special. So far, we have talked about refraction of light and how lenses work. We talked about the phenomena of refraction, convex lenses, concave lenses, how light, what is a diopter, how images are formed by light rays, lens interactions. Then we talked about the optics of the eye, the reduced eye, the fixed power of the eye, the length of the eyeball. Then we talked about emmetropia, how light rays from distant are focused on the retina. Then we also talked about how the eye can adjust and focus near light rays, the process of accommodation. Now we'll talk about errors of refractions, or error of refraction, or refractive errors. Refractive errors are simply a fault in the mechanism of refraction which produces a blurred image on the retina. They can be for near, which is called presbyopia. It's also called a reading error. They can be for distance, which is called ametropia, and can be of one of these three types: hyperopia, hypermetropia, myopia, and astigmatism. And it is possible that near and distant vision error coexist in the same patient. This is how they're classified. So you have refractive errors of near vision, presbyopia; of distant vision, ametropia, or mixed concurrent near and distant vision. We'll not talk about it as a separate entity, because as we talk about these refractive errors, it's just that both of these coexist, and they would coexist because of fundamentally the age of the patient, as we'll see. So distant vision errors could be myopia, hypermetropia, hyperopia, they're the same thing, and astigmatism. And we'll just talk about them one by one. We'll start off by near vision error first. And near vision error are called presbyopia, and this is gradual loss of accommodative amplitude leading to blurred near vision. Presby is old, opia is sight, old sight. It's also called a reading error or a near vision error. And what happens is, as you grow older, the ciliary muscles can't contract as much as before, so your lens can't accommodate as much as before. So your accommodative amplitude decreases, so the near objects are blurry. And the most common thing that this is noticed during is reading, because the most common thing that you should be doing with your eyes at near is reading. And as you age more, your ciliary muscles would become weaker, and this presbyopia would become worse with advancing age. So how do these patients present? Well, they are obviously going to present with gradual and painless decrease in vision for near work. Near work is usually defined differently by different individuals. People who like to use a cell phone usually describe cell phone reading distance as near work. People who would do desk work would define that distance as desk work. People who are jewelers would define even closer distance to their eyes as near work. So this near work would obviously mean different things to different people, and we need to take that into account. It usually starts at 40 years of age. And think accommodative amplitude, that blue rectangle or square that was around that particular age group when I showed you the chart. And one very characteristic thing that patient would say is that if they move an object a little bit further away, it becomes clearer. And you already know why that is, but we'll talk about it in a minute. And obviously, the patient might already have a near vision issue and he's just coming in for a change of glasses, or he might already have a distant vision issue in which he was wearing distant vision glasses. And that was because he was wearing those glasses before he reached a presbyopic age, which is usually 40. Not always, but usually, because the most common reading distance is 0.25 meters or 25 centimeters. And if we take that into account, presbyopia starts at 40 years. We'll see that in just a second, and it'll be very, very clear to you. And again, as I said, near would mean different to different people. Computers, cell phone, books, newspaper, television, different people have different near vision requirements. But let's take the most common near vision required distance, which is 0.25 meters. We have seen this picture before. You have a cell phone, which is 0.25 meters away from you. The light rays reaching your eye would have a power of -4. The lens in the eye would simply accommodate, raising the power of the eye to 64, which would neutralize the power of these incoming light rays, so that the emergent light rays have 60 diopters and can focus on the retina. So the problem would be, take this 40-year-old school teacher who says he or she can't see clearly at 25 centimeters. Obviously, she or he is not going to say 25 centimeters. They will say can't see for near, which is usually considered to be 25 centimeters. So this was the circle that I showed into you before as blue. Now it's in red. And as you can see, when you're closer to 40, the accommodative amplitude drops to 3.3. And you need an accommodative amplitude of 4 to neutralize light rays that are coming from 0.25 meters because they have a power of -4. So this individual, this teacher, can't take his lens to his power of his or her eye to 64, can only take it to 63, approximately 63, 63.3. Let's take it 60, make my life a little easier. And if we add -4 to 63, we don't come up with 60, we come up with 59. So these light rays focus behind the retina. And there is really nothing you can do about it. It is a blurry image, but the eye can't accommodate anymore because it does not have any more power to raise its power. The ciliary muscles don't have any more power to raise the power of the eye anymore. So this person would have blurry near vision, and that is what presbyopia is. That is how they present. And to correct presbyopia, obviously we need to give this person some form of additional power. And that power would depend upon the age of the patient. Remember, as you grow older, the accommodative amplitude would become even worse simply because your ciliary muscles are getting weaker and weaker. And also it would depend upon near requirement. A computer operator would have a different requirement as compared to a tailor. A computer operator might put his screen at 0.5 meters, while a tailor would be working at 0.25 meters. That is why it is essential that when you are testing near vision, and I've repeated this in the video of near vision skill, that you don't ask the patient to read the near vision chart from a distance where he can read it from. Ask him where he wants to read it from. And as you'll see, and as most people who present with near vision can simply say, if I increase the distance, I can actually read. So when you tell a patient, oh, read this chart, he will just put it here and read it, and you'll say your near vision is fine. When his near or her near vision is not fine because he can't or she can't read from where they want to read from. So you tell the patient, put this chart where you want to read from, not where you can read from. He, she, and again, it's used as a universal pronoun. So how do we correct it? The first thing to remember is refractive errors can be corrected, they cannot be cured. Whatever accommodative amplitude has been lost is lost, so we are just going to correct whatever has been lost. All of the methods that I'm going to list are suitable to correct presbyopia except one. I am only putting this method one because this is a way in which many of these individuals initially correct their own error. And that is just increase the distance at which the near object is. How that works, I'll just tell you in a bit. It's not feasible, it's not practical. This is not something that you will write or answer to in an OSCE or write an answer if it's a MCQ, because this is not an acceptable method of correction. Patients themselves use it to correct it, and we need to understand how this works, but this is not a prescription method. Spectacles is the oldest, safest, and the most reliable method. We also can use contact lenses. Contact lenses can correct both for distance and near, or just for distance or just for near. We'll just talk more about contact lenses when we talk about correcting distance and near vision, distance and near refractive errors simultaneously, so that we don't have a lot of repetition. You can also use laser. Lasers have traditionally been used to correct distant vision errors. They can also correct near vision errors, and the process is called Presby-LASIK. LASIK stands for laser in situ keratomal uses. We'll talk more about LASIK when we talk about distant refractive error correction. And what it does is it turns your cornea from a unifocal structure to a multifocal structure. Remember, cornea provides 42 diopters of power, which is good enough when we talk about a person who is focusing for distance or near, but not at the same time. And it changes its power so that both light rays near and distance can focus onto the retina at the same time. You have to have very good patient selection for this. Not everybody is comfortable with light rays from distance and near focusing at the same time, because you consciously have to make an effort to focus at one of them. So these individuals you need to have very good patient selection. Tell them, look, you need to choose which things you want to see, and if you would like very good near or distant vision, don't get it done. It's only if you don't want to use spectacles at all, get this done. So it's not the best procedure, unlike lasers for distant vision, but this is something that can be done. So let's see how this increasing distance of object works. Again, this is not a prescription method. This is not a prescription method. It's something that patients do. So the same teacher that we started off before, and this was his state, -4 is the light rays coming from the cell phone, the power of the light rays. He can only take, or she can only take, his power to 63 diopters now because of decreased accommodative amplitude because of age. so that the power of emergent light rays is only 59, which focus behind the retina, because you need 60. So one thing you can do is simply move this further away. Let's say you move it to 33 centimeters, 0.33 meters. Light rays would then have a power of -3. This individual can raise his eye to 63 diopters because he has or she has a accommodative amplitude of 3.3, so that the emergent light rays would have 60 and focus on the retina. This is not an appropriate method of correcting presbyopia. It's not a prescription method. It's a method by which patient overcomes this error on his or her own. We are talking about it because you need to understand how it works, not because you want to prescribe it. The most common way of doing it is using spectacles. And what we want to do, we need to add power to the eye. Which of these lenses was adding power? Obviously, it's the convex lens. So we put a convex lens. And the power of the convex lens would depend upon the deficit in accommodative amplitude, which in this case is 1. So we put a +1 convex lens in a spectacle, and this person would be good to go. So the power equals to the deficit in accommodative amplitude of whatever the patient requires. Lenses are prescribed in reading spectacles. Reading spectacles are pre-made with specific power, which is age-based correction. I'll show you a table, which is right here. This is the age. This is the accommodative amplitude remaining. This is the deficit from 4, and we are considering 4 because we are taking the near vision distance as fixed 0.25. This will not work for everyone, but this will work for the majority of the people, the population. People who use computers for near work would require a different correction because their distance is slightly more. People who are working very close to their eye obviously would require a different power. But the majority of the population would want to or usually works at 0.25 meters, and this table would work for them. This is just age-based correction because we are taking the near working distance as fixed, and we are just making up for the deficit in accommodative amplitude. For example, if you have the same school teacher who is 40 years of age but wanted to work from a computer, he wouldn't experience presbyopia here, because a computer is usually 50 centimeters away, which would mean that this would be -2, and he still has 3.3. So as I said, it usually starts at 40 because the most common working distance is 0.25 meters, but this is rapidly changing, especially now because we don't have as many desk jobs with files which are physical lying here. We have monitors that are a little further off in terms of a laptop monitor or a discrete standalone monitor. But still, this is the way that most of the time you prescribe near visions based on the assumption that the working distance for near would be 0.25 meters. If it's not, it's very simple. We are just making up for the deficit in the accommodative amplitude. If this teacher wanted to work from, let's say, rather than 25 centimeters, 20 centimeters, this would be 5. This would still be 63. So 5 minus 63 would still be 58. So rather than +1, you'll give him +2. So if it's very simple, it's just the deficit in accommodative amplitude that you are making up for that working distance of a patient. This is what presbyLASIK is, and this is on the left is a normal unifocal cornea of 42 diopters power, which would either focus for near or distance depending upon where the patient is looking for. This is what presbyLASIK does to the cornea. It creates various zones in the cornea. So this zone right here in the center here is the near zone. Remember, when you're looking for near, your pupil constrict. So this is the zone that would still be open because the size of the pupil would be this much at least. The iris would constrict, the iris would contract, and the pupil would become smaller, but this area would still be visible when you're looking for near. So the near zone is always in the center because your pupils constrict when you look for near. The zones around the near zone are for intermediate and distance zones, and when you look for distance, the pupil dilates so that light rays from those distant objects would focus on the retina. So the parallel light rays are from distance, the diverging light rays are from near. And as you can see, when this patient is looking for near, both distance and near light rays are focused on the retina, so the patient actually has to choose which object to look at. This problem is not so much for near, because when you look for near, the pupil constricts, the iris constricts, it will block these light rays, but this would still reach the retina. So near is sort of all right. Distance is a problem when both distance and near light rays are focusing on the retina. But you tell this patient, and many patients who are sitting at home most of the time are comfortable, it's mostly who drive a lot themselves would have a problem focusing on light rays coming from distance and ensuring that near light rays are not interfering with their vision. So patient selection is important. Now we'll talk about distant vision errors or ametropic errors. We'll begin by defining ametropia, which is a distant refractive error, which is basically light rays coming from distance, a distance of 6 meters or more, that are not focused on the retina when the eye is not accommodating, i.e. the eye is at rest. Remember, accommodation is a phenomena that allows the eye to adjust for light rays coming from near, a distance of less than 6 meters. So ametropia is A meaning not, meter meaning measure, and opia meaning vision. Now, we've also used this term, emmetropia, which was a term used to define people who are able to focus light coming from distance, i.e. a distance of 6 meters or more, on the retina without any accommodative effort. And that was M for equal, meter for measure, and opia for vision. So ametropia is a distant refractive error, and emmetropia is a normal eye which is able to focus light from distance on the retina without the use of accommodative effort. Ametropic errors or distant errors are defined following certain rules or principles, which are that light rays are parallel, i.e. coming from infinity or distance. For ophthalmologists, that's a distance of 6 meters or more. Yeah, for ophthalmologists, 6 meters is infinity. We can't see beyond that. No, I'm just joking. It is what it is, and it is considered infinity because the light rays are more or less parallel if they're coming from a distance of 6 meters or more. They're not exactly parallel, but they can be considered to be parallel. The eye is at rest, i.e. the eye is not accommodating. Again, remember, accommodation is a phenomena that allows the eye to adjust for light rays that are coming off a near object, a distance of less than 6 meters. The refractive errors are defined on the basis of where light rays are focused in reference to the retina. If they are focused behind the retina, it is called hyperopia or hypermetropia, which means long measure. If they are focused in front of the retina, it is called myopia, which is short measure. And if they form a stigmatic focus, it is known as astigmatism. What's an astigmatic focus? We'll get to that in a bit. And the distant refractive errors or ametropic errors arise because of a difference in power and or the length of the eyeball that does not allow the light to focus on the retina without the use of accommodation. So let's talk about their demographics and etiology. They can present at any age, these distant refractive errors, as opposed to presbyopia, which presents usually at the age of 40 years. They affect all genders. There are region-based variation in genders, but they affect both males, males and females. These days we are sort of living in a gender, what's the word for it? Ambiguous society. So let's just call it affects everyone. Myopic errors are the most common of the two types. They present at an earlier age as compared to hypermetropic errors. And the earlier the patient presents, the greater the magnitude of the error in the long run. The etiology of myopia is generally genetics, which is also possible that it's only genetics that's responsible for myopic errors. They're also associated with many syndromes like congenital glaucoma, connective tissue diseases like Marfan syndrome, and aging also. When we do refractive errors, this bit will become more clear, but suffice to say right now that as you grow older, your lens increases, the refractive index of the lens increases, which makes your eye more powerful, which makes your eye myopic. It's called myopic shift. It's also called second sight. And we'll talk about it when we talk about refractive errors. Hypermetropic errors are usually masked and they present later in life. How are they masked? Why are they masked? We'll talk about it. But this is not like for every case. It is possible for hypermetropic errors to present at a younger age, especially if their magnitude is really high. Their genetics, their etiology hasn't really been that well studied. Their genetics might have a role, but really there is nothing definite that's been documented as of when this video is being recorded. So we'll talk about hyperopia or hypermetropia first, and hyperopia or hypermetropia is parallel light rays which are coming from a distance of 6 meters or more, i.e. infinity, focused behind the retina when the eye is at rest or not accommodating. And this is happening because the eye does not have sufficient power, or it has too short a length, or both of them. So depending upon where the deficit lies, you can have hypermetropia that is refractive, in which the cornea is too flat, the power of the cornea is less than 42, so the total power of the eye is less than 60. It can also be index, where the lens is too thin and the power of the eye is again less than 60. In this case, it's because the power of the lens is less than 18. It can be axial, which is also the most common cause of hypermetropia, in which the length of the eyeball is too short so that the light rays focus behind the retina. The power of 60 diopters is not enough to focus the light onto the retina. You can have more than one cause in one eye, so you can have refractive index, and axial, all three coexisting together. You can have any two or any one. By far the most commonest type, which is responsible, the most common classificative, which the most common type of hypermetropia is axial hypermetropia, because the eyeball is too short. So if this is this patient, is it possible for this patient to overcome involuntarily his or her refractive error? Can this hypermetropic patient involuntarily overcome his or her hypermetropia? And if you think about it, the light rays are focused behind the retina, which produces a blurred image to the patient. And this blur can involuntarily stimulate something which can help this patient. And that something is accommodation. Remember, accommodation is something that is triggered when there is a blurred image on the retina. Remember I said, if you remember this thing, it will clear up a lot of confusion. So this hypermetropic patient will involuntarily accommodate. And if this patient has enough accommodative amplitude to overcome his or her refractive error, the refractive error would be masked. The patient would not even know of the refractive error, and this is called latent hypermetropia. And these patients are called latent hypermetropia. It is latent hypermetropia simply because the patient does not know he has hypermetropia, because the effect of accommodation in this patient has involuntarily overcome the refractive error. That is why hypermetropes at times, most of the time, do not present at an early age, because the younger you are, the greater the accommodative amplitude you have, and the greater the refractive error that can be masked. And that is why most hypermetropes don't even know they are hypermetropes, because they are using accommodation, something that's not supposed to be used for distance, but it is, because accommodation is triggered anytime there is a blurred image on the retina. And with hypermetropia, you have a blurred image because the light rays form behind the retina, creating a blurred image. And if the patient has sufficient accommodative amplitude, he or she will be able to focus these light rays onto the retina, not know that they are hypermetropes, thus latent. Latent means hidden. So these are latent hypermetropes, and this phenomena, or this, is called latent hypermetropia. As long as these patients have sufficient accommodative amplitude to focus distant light rays and also to allow comfortable near work, they would remain asymptomatic. But as they're growing older, the accommodative amplitude is decreasing, simply because the ciliary muscles are getting weaker, and these latent hypermetropes, or their latent hypermetropia, would become apparent, or would become symptomatic for them when there isn't enough accommodative amplitude left to provide clear near and distant vision. And now this hypermetropia is called manifest hypermetropia. Manifest is something that's visible, or is something that is seen. So now these patients are becoming symptomatic, and their symptoms are very interesting. Rather than coming in and saying they can't see clearly for distance, they usually say that they have discomfort with prolonged near tasks. And that's very interesting. Although this is a distant refractive error, hypermetropes usually, not always, present with difficulty in, or discomfort is a proper word, or a more appropriate word, with near task, in spite of the fact that this is a distant refractive error. And we'll see why that is in a bit. And let's take this example to sort of explain why this happens. So you have a 32-year-old teacher who complains of inability to read from 25 centimeters, our default near distance, with a distant visual acuity of 6.6 in both eyes. What is wrong with this statement? If you read it again and read it carefully, 32-year-old complaining of near vision issues with a distant vision of 6.6. And if you still don't get it, you should just go back and read what presbyopia was. A 32-year-old person shouldn't have trouble reading from 25 centimeters because at this age there is enough accommodative amplitude left to allow comfortable near vision from 25 centimeters. So it goes without saying that some of this accommodative amplitude is being used elsewhere. And guess where else it could be used? It could be used to focus parallel light rays on the retina while the eye is accommodating. So the provisional diagnosis is that this patient right now is a latent hypermetrope of an X magnitude. We don't know the magnitude yet. We would need to use certain devices or instruments to figure out the magnitude of the refractive error. But right now, what we are assuming is, or what our hypothesis is, that he is using some of his available accommodative amplitude of X to bring his or her eye to an emetropic level. And remember when we were talking about presbyopia, and before that when we were talking about accommodation, reflex, and near vision, the accommodative amplitude always works from a base power of an eye of 60 diopters. Now these hypermetropes, these latent hypermetropes, obviously are not going to have 60 diopters of base power. They're going to have less power. Remember, the cornea is too flat, or the lens is too thin, or the amount of power is not sufficient for these patients if it is axial hypermetropia. So for either of these reasons, the lens starts accommodating to get the base power to 60. So right now, our patient does not have a base power of 60 because we are assuming that he is a latent hypermetrope. So some of that power is being used, some of the accommodative amplitude is being used to bring the power of the eye up to 60. So now, whatever accommodative amplitude it is less than 4 diopters, which whatever is left behind after we subtract X from it. We are subtracting X from it because we are assuming that this is the X, which is the amplitude of hypermetropia, which is being overcome by accommodative amplitude. Remember, right now he's complaining of near vision. His distance vision is 6.6, so he's using some of his accommodative amplitude to fix his distant vision. We don't know that X yet, that the magnitude of the accommodative amplitude used, because we need instruments for that. We'll talk about those instruments in a bit. But right now we are saying that of the total 4.5 diopters of accommodative amplitude available at 32 years, he is using X for distance, leaving less than 4 behind. Because we need a power of 64 diopters to see comfortably from 25 centimeters, because the light rays coming from 25 centimeters have -4 power. We need the power to be 64 to neutralize that -4, so that the light rays emerging have a power of 60 diopters and can focus on the retina, which is clearly not happening now because he is using some of his accommodative amplitude to fix his distant vision. And we need to prove this now. In order to prove this, we need to take his ability to accommodate away, because that's the only way we can figure out what is his or her true distant vision. Because right now he is or she is masking the true distant vision by accommodating. So we need to paralyze those ciliary muscles so that this patient cannot accommodate. And when this person cannot accommodate, the light rays would focus behind the retina, because we are assuming he is a hypermetrope, and then we can figure out what is the magnitude of the refractive error by using certain instrumentation. So to establish diagnosis, we need to paralyze accommodation with a parasympatholytic agent. Remember, it's a parasympathetically driven system. So we need a cycloplegic drug, which is a parasympatholytic drug. We'll talk more about parasympatholytic drugs in just a moment, about 5 to 10 minutes from now, hopefully, to determine if this patient is hypermetropic, because unless we paralyze accommodation, this patient is going to be using his accommodative amplitude to fix the vision. Even if we put him or her in front of a machine and try and measure the refractive error, invariably the patient will try and accommodate. No matter how good the machine is, even the most modern machines, if the patient is consciously making an effort to see clearly, he or she would initiate accommodation, which would then mask the refractive error again. So we need to paralyze accommodation in order to figure out the true refractive error in this patient. So this is why hypermetropia is a little tricky to understand, because most of the time hypermetropia hypermetropes, sorry, have good distant vision because they are latent hypermetropes. They're using a part of their accommodative amplitude. And most of the time when they present with a very odd near vision issue when the refractive error is for distance. And you wouldn't believe it that many ophthalmologists and opticians would actually correct these patients for near, just correct what the patient is complaining of and be on their way, be on their merry way, which isn't correct. You need to figure out whether we are looking at a latent hypermetrope. And the only way to do that is the only true and honest way of doing that is to parallelize accommodation. And the presentation is odd, like the one that we have seen, a 32-year-old teacher inability to read for near, which is kind of odd. If this were to get even worse, this patient can complain of inability to read for near and distance. If the X was so high, greater than 4.5, this patient wouldn't be able to look for near or distance because 4.5 is the total accommodative amplitude available. And if the hypermetropia is of greater than 4.5 diopters, this patient wouldn't be able to focus distant or near light rays and would say, I can't see for distance or near. Na dur ka nazar aata hai na kareeb ka. So these peculiarities can be picked up if you're good at history taking. And even a family physician or a general practitioner who eventually is not going to be dealing or prescribing can explain to the patient, look, you have a refractive error, go to an optician or go to an ophthalmologist, because clearly what you have is not a near vision error. It doesn't happen at this age. You need to have a proper test done to figure out what sort of refractive error you have. So again, if we start correcting hypermetropia, we need to obviously add power to the eye. And the lenses that add power to the eye are convex lenses or plus lenses. And the magnitude of refractive error would be determined using instruments. And those instruments are either automated refractometer or retinoscope. We'll talk about these two in a bit. And this is the same lens that we use in presbyopia, because in presbyopia, the eye again was deficient in power and we needed to add power. And just because we are using the same lens doesn't mean they're the same refractive errors. Presbyopic errors were for near, light rays were diverging. Hypermetropic errors are for distance, light rays are parallel. So let's let's discuss the abuse of this terminology, long-sightedness. Hypermetropes have also been, this refractive status has also been called long-sightedness. In fact, many medical textbooks describe this as long-sighted, and they are called long-sighted because they involuntarily use their accommodation for distance. This assumption is wrong because the very definition says eye is at rest, and that's how we define it as parallel light rays, eye is at rest, light rays focusing behind the retina. So when we are saying parallel light rays are focusing behind the retina, how can we say that they are long-sighted? It's ridiculous. This term creates so much confusion. You just remember long-sighted and you say, oh, their distant vision is fine, the problem is with near vision. There is no problem with near vision. The problem is with distant vision. Don't use this term. It creates confusion. If you want to use it knowing what it means, and use it with your patients, explaining to them properly why is it called what it is called. Words have meanings and they shouldn't be abused. So hypermetropia recap, it's a distant refractive error. Parallel light rays focus behind the retina in a resting eye. Resting eye would mean non-accommodating eye. This happens because of the reasons that we have talked about, eyeball too short, too flat cornea, too thin a lens. The eye can potentially and involuntarily compensate for this by accommodating. And this is corrected using a convex lens or a plus lens because power has to be added to the eye. And just because presbyopic errors and hypermetropic errors are both corrected by plus lenses does not mean they're the same error. Presbyopia is for near, hypermetropia is for distance. Please remember that. Long-sightedness is a term that creates confusion. Understand what it means, and it refers to latent hypermetropia. So you use it while understanding what it means and also make your point clear to everybody else. Now we'll talk about the other refractive error, which thankfully is not as tricky as hypermetropia, which is called myopia. Myopic refractive errors occur when parallel light rays focus in front of the retina when the eye is at rest, i.e. not accommodating. And this happens because this time the cornea is too curved, has too much power. So the power of the eye is more than 60 diopters because the power of the cornea is more than 42 diopters. That is described as refractive myopia. Index myopia occurs when the lens is too thick so that the total power of the eye is more than 60 diopters, and this time because the power of the lens is greater than 18 diopters. The third one is called axial myopia, which is the most common cause of myopia, in which case the eyeball is too long so that the light rays are focusing in front of the retina because the eyeball is too long. And again, you can have more than one of these three factors that contribute to a myopia in a patient, but again, axial form is the most common form. And again, let's see if accommodation has a role here. Because remember, every time a blurred image is formed, accommodation is stimulated. The process of accommodation is stimulated, and you will have a blurred vision because the light rays are focusing in front of the retina. But if you increase the power more, as it happens in accommodation, things would get worse because the light rays would move even further away from the retina because you're increasing the eye power when the eye already has too much power. So yes, accommodation will start, but no, accommodation will have no role in this because accommodation will make things worse. And that is the reason that myopes are usually caught early. You have, when you have little kids and if you have little kids in your family, parents are very fond of asking their children to read from distance to see how good their vision is. It happened to me, and I'm sure it happens to the most of you, simply because I have lots of patients who are coming in, bringing in their children, complaining of the very same thing. My child cannot read the board that I can. And hypermetropic children can cover their error very easily, but myopic children can't, because there is no way you can cover your myopia. So you ask a myopic child who is just starting to learn her ABCs or his ABCs, and you say, can you pick out A? They won't be able to pick out A because they can't see the A. There is no way they can compensate for it. But if you ask a hypermetropic child because children have a lot of reserve accommodative amplitude to read from the billboard, hey, can you point out to an A? They probably will point out to an A because although they are hypermetropic, they can use some of their accommodative amplitude to overcome that error. But no way you can overcome myopia that way because accommodation has no role. It actually makes things worse. So no role of accommodation in myopia. So myopes always require some form of a corrective aid in order to overcome the error. And this time, because the eye has too much power, we need to reduce the power of the eye. So we are going to use a negative lens or a diverging lens. The magnitude of the lens is obviously determined by using instrument which is either an automated refractometer or a retinoscope. There are certain characteristic features of myopia. Remember, most of the refractive errors usually start off at a young age. And as you grow older, the magnitude can change. The younger the onset of myopia, the greater the magnitude of the error over the lifetime of the patient. The most common type of myopia that's usually observed is called school-going myopia, which usually happens or is apparent in kids who are just about to go to school, and it usually tends to limit itself to -3. But not always, usually. Remember, there is no always in medicine because unfortunately diseases cannot read books, they cannot read at all, and they do what they want to do. They're like cats. They do what they want to do. There is another very peculiar type of myopia. It's called pathologic myopia. And the definition of pathologic myopia is that when you have axial myopia of 6 diopters or more, the eye starts showing degenerative changes because the eyeball is so long, it's starting to degenerate. And this is called pathologic myopia. And this is a slow process. It's not something that's going to happen over days or weeks. It's a slower process. So it involves the patient constantly every year going to the ophthalmologist and an optician to get his or her eye checked to ensure that this degeneration is not going to lead to a more dangerous thing that we'll just talk about. So how do they present? Obviously, they're going to have gradual painless loss of vision, but the characteristic clinical finding that makes pathologic myopia is the presence of a staphyloma. Remember, the eyeball is constantly stretching, so all of the layers of the eyeball, the choroid, the retina, and the sclera are getting stretched and getting thin. And the sclera, which is the outermost covering of the eye, gets thin, and because of the pressure within the eye, which is called intraocular pressure, a bit of the sclera at the posterior pole, which is where the sclera is thinner, and because of all the stretches becoming even thinner, it develops a little bit of an outpouching, which is called a staphyloma. And the choroid and the retina tend to follow the sclera into that staphyloma. And the retina is really thin. It's a very thin, delicate neural tissue. And as it stretches into the staphyloma, it can actually develop a break, which can lead to retinal detachment. And this is the thing, this retinal detachment, amongst other things that can happen in pathologic myopia, that can cause devastating visual loss, even permanent visual loss. So that's something which requires yearly eye examination to ensure that this doesn't occur. Because when we will talk about retinal detachment, when we talk about sudden painless loss of vision, there are certain prophylactic steps that can be taken in order to prevent this retinal detachment from happening in patients who have pathologic myopia. So this is a normal eyeball. This is an eyeball that's stretching. You see it's longer. It has axial myopia, and this is a formation of a staphyloma, this outpouching right here. And although this is a really difficult picture to understand, this is the optic disc, and this area surrounded by black arrows is the staphyloma. It's very difficult to show staphyloma here, especially when you look at the retina, because it's very difficult to show something in depth because it's a flat picture. But this is what's happened. This is the sclera, this brown tissue is the choroid, and this yellow tissue towards the inside is the retina. This is the vitreous in blue. So all of these layers are following the scleral outpouching the staphyloma, and here the retina can actually break, which can eventually result in a retinal detachment. We'll talk more about retinal detachment when we talk about retinal detachment. So another peculiarity of myopia is myopia and presbyopia, or rather lack of presbyopic symptoms. Uncorrected myopes have late onset of symptoms of presbyopia. Their presbyopia is usually presenting after 40 years, as compared to emmetropes, people who have perfect distant vision. And it's not that difficult to explain, because remember, myopes have more than 60 diopters power or more than required power, and presbyopia is a deficit in power. So take this example of a 40-year-old emmetrope and requires +1 lens to read comfortably from 25 centimeters. We've already talked about why this is. So light rays coming from 25 centimeters or 0.25 meters will have -4 power. This individual only has 3 diopters or 3.3 diopters of accommodative amplitude left. We already know this. We have seen the table. So -4 plus 63 would be +59. So we gave him +1 corrective lens, convex lens, to bring the power of the eye to 60. Let's look at this myope who would have the same amount of accommodative amplitude at 40, because this myope's muscles are also getting weaker. So the light rays that are coming from 25 centimeters again have a power of -4. This individual can only raise his or her eye power to 63. So again, -4 plus 63 should be 59, but it's not, because if this is a myope of -1, this person's eye power is already 61. A myope of -1 would mean that this person is wearing a -1 lens to neutralize the additional power of his or her eye. If the neutralizing lens is -1, the additional power is 1. So the power of the eye in this case is 61 rather than 60. That is why he was prescribed -1 to bring the power of the eye back to 60. But if this person is not wearing his glasses or her glasses uncorrected, the power of the eye would be 61, because we don't have that -1. And so 61 plus 3 is 64, and -4 plus 64 is going to be 60 again. So for myopes, in the myopes case, -4 incident light ray plus light rays, not lays, plus 3 lays is a pack of chips, crisps, plus 3 is the maximum accommodative lens power, plus 61 in this case rather than 60, because this is the total power of the eye with myopic advantage, which brings the net power to be 60. So myopes can read comfortably even at 40 from 25 centimeters without their correction, as compared to emmetropes who can't. So the people that you've been making fun of all their life for wearing glasses for distance, just wait till they're 40 years of age. Then we'll see who's laughing. Those who laugh last laugh the longest. Let's talk about the abuse of the term short-sightedness. Myopes have been called short-sighted, and they've been called short-sighted because their near vision is normal or better than distant vision. And we have seen why that is, because their eye power is more than normal. So they're comfortably doing near vision tasks most of the time. But this assumption is wrong. Even hypermetropes, once you correct their hypermetropic error, have normal near vision. The reason hypermetropes usually do not have good near vision, or their complaints or symptoms start off with deteriorating near vision, is because they're using some of their accommodative amplitude to fix their distant vision. But once you have taken care of their hypermetropia, their near vision is just as good as that of a myope, i.e. normal, or emetrope to be more precise. So do not use this term. It creates confusion. When you're talking about ensuring short-sightedness, it means that myopes have good near vision, their distant vision is bad, and this is something that's specific to the domain of myopia, and hypermetropia must be the other way around. So not only are you sort of, distorting the concept of myopia, you're also distorting your concept of hypermetropia at the same time. So do not use this term, or if you want to use this term, make sure you know what it means and implies. Thank you. So let's recap myopia. It's a distant refractive error. It's a distance vision refractive error. Parallel light rays focus in front of the retina in a resting eye. It cannot be automatically compensated for accommodation simply because accommodation makes things worse, because it is increasing the power of an eye which already has too much power. It is corrected by using a concave lens because you want to reduce the power of the eye, which is different from presbyopia and hypermetropia. Now we'll talk about astigmatism, the third type of our distant refractive errors. So far, we have talked about far and near vision errors. See what I did here? So far, as in so far, and far. I know, I'm old, my humor is old. So we talked about distant vision errors and near vision error. And in all of these errors, we were talking about light rays not focusing on the retina, but only producing one focal point. Now we'll talk about a type of refractive error, astigmatism, in which there is more than one focal point. There are two focal points, and we'll see how that is. Before we go on and actually talk about astigmatism, let's just look at these two spherical shapes or geometrical objects and try and figure out how they are geometrically different from one another. And the best way to describe that is by their radius of curvature. In spheres, the radius of curvature remains the same no matter if I am talking about its horizontal or vertical axis, or x or y axis, or x or y meridian. But in ovals, the curvature would change depending upon which of the two meridians is more curved, or which of the two axes is more curved. Now your cornea can also be like a sphere or like an oval. If your cornea is like a sphere, its power in the horizontal and vertical meridians will be equal. If you are an emetrope, you would have 42 diopters of power along x and y meridians, or horizontal or vertical meridian, or horizontal or vertical axis. However, if your cornea is shaped like an oval, its power would be different in the two meridians, because one meridian or one axis as compared to the other would be more or less curved, and the more curved meridian would obviously have more power because it's more curved. So it would have more power. It will be sort of thicker along that direction. So this is flat, this is curved in red. So this meridian, the x meridian or the x-axis, which is more curved, would have more power. Here, both of them are equal, so they would both have equal power. So again, let's talk about spheres and a spherical cornea. Both in an emetrope, both of these meridians would have 42 diopters of power and would focus at one point, because both meridians have the same power. So you'll have a single point focus, which is called a stigmatic focus, which is good. This is what you want. But this is not always true. Sometimes what happens is your cornea becomes rugby shaped. So you have a flat meridian and a curved meridian, and let's assume that the flat meridian has a power of 42 diopters and a curved meridian has a power of 44 diopters. Let's bring in our light rays. They won't focus at one point because the power in the two meridians is different. Now you will have 2-point foci. Astigmatism, not point focus. So human corneas can be like spheres and they can also be like ovals. If they are like ovals, you will end up in astigmatism. And astigmatism would produce very similar symptoms to the other type of refractive error, in which there would be a gradual painless loss of vision, but they would also have a little bit of peculiarity. They would be misreading letters because there are 2-point foci. So an O might appear to be a P, and things like that. So that gives you a clue as to this. You might be looking at astigmatism. This is another rather good picture of the eye showing the cornea that looks like a rugby ball or an oval, producing two foci, one in front of the retina and one behind the retina. And obviously, depending upon the power of the cornea, there are multiple possibilities, and we'll talk about those possibilities momentarily. So let's see how astigmatism is corrected. So you have a flat meridian and a curved meridian, and let's say none of these have the normal power. So a flat meridian is focusing light behind the retina, so it has less than 42 diopters of power, and the curved meridian is focusing light in front of the retina, so it has more than 42 diopters of power. Let's try and correct these, and let's start by correcting the flat focus first, the vertical focus. And this, since the light rays are focused behind the cornea, or behind the retina, sorry, we need to add power to the eye. So let's add power to the eye, convex lens. This will bring this focus back here, which is very good. But what would happen is that this focus would also be shifted away from the retina, because a spherical lens, if you remember from the definition, irrespective whether the light is coming from x-axis or y-axis, it is all going to be converged. So good, our convex lens focused one of the meridians or axis, and we were trying to focus the flat meridian. It did that. It brought it onto focus on the retina, but it also disturbed the other focus, the more powered or a curved focus, and it moved it even further off the retina, which makes things worse. So now what we need to do is, if we use a concave lens to fix this meridian, it would fix it, but then it would disturb the other meridian, because a spherical lens changes the position of all light rays irrespective whether they are passing through x-axis or y-axis or vertical or horizontal meridian. What we need is a lens that only works in one meridian or one axis, and that lens is called a cylindrical lens. And this is how a cylindrical lens works. Rather than bringing light to a point focus as shown by these blue light rays, it brings the light into a line focus as shown by these green light rays and this red line. So what we do now is we fix one focus with our spherical convex lens, which is good. It will move both these foci, understandable, we already know that. But to correct this curved focus, we would put our cylindrical concave lens aligned along the horizontal meridian or the x-axis, so that the curved focus only moves now. That's the beauty of the cylindrical lens, works only in one meridian. And now we have both light rays focus on the retina. So in order to correct a astigmatism or astigmatic refractive error, we need a cylindrical lens. We may also need a spherical lens depending upon how many of these two foci are off the retina. So astigmatism, not point focus, is corrected using a cylindrical lens. As I just said, that depending upon how many of the two meridians are off the retina, i.e. not focusing the retina, you may require a spherical lens in addition to a cylindrical lens. Let's look at all the possibilities that can happen when your cornea is an oval shaped cornea rather than a spherical cornea. So you can have one of the two meridians has normal power, 42 diopters, and the other meridian has more than 42 diopters of power. So one of the meridians will focus on the retina, but the other meridian will focus in front because it has more power, and this is defined as simple myopic astigmatism. You only need a cylindrical lens to correct this because one of the meridians is already focused on the retina. Let's look at picture B, in which one of the light rays is focusing on the retina. So this meridian has 42 diopters of power. The other meridian and axis are the same thing. I hope you know that. I've said it before, but repeating just for the sake of, repeating. The other meridian or the other axis is focusing behind the retina. Here, this meridian, which is focusing behind the retina, has less than 42 diopters of power. Again, you would only need a cylindrical lens. In the first case, we needed a cylindrical concave lens. Now we will need a cylindrical convex lens. We don't need a sphere in A or B because one of the meridians is already focused on the retina. We don't need to change its position. We only need to change the position of the other meridian, which is not focusing on the retina. Let's look at picture C, in which both the meridians are in front of the retina. That means both the meridians of the cornea have more than 42 diopters of power. Here we would definitely require a sphere which would focus one of the light rays or one of the meridians on the retina. It would disturb the other one as well, but the other one we can simply take care of by using a concave cylindrical lens, or concave sphere and a concave cylinder will help eye see focused light appropriately. In ID, 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 in this eye, compound hypermetropic eye, both the foci are behind the retina. So that means both of the meridians of the cornea has less than 42 diopters of power. And again, here we would need a spherical lens as well as a cylindrical lens to correct this error. In this case, both of these lenses are going to be of the plus type or the convex type, because in both meridians, the cornea has less than 42 diopters of power. That is why light rays are focused behind the retina. Finally, mixed astigmatism. This is the example that we used before, and since we've already done it, I'll just mention it for you. We needed a spherical lens and a cylindrical lens. One of them has to be a concave lens, the other can be a cylindrical. If we correct the hypermetropic focus, the one with less than 42 diopters power with a spherical lens, the other one would be corrected by a concave cylindrical lens, and vice versa. So we have 5 different types of possibilities arising out of a cornea that is shaped like an oval. And these are the types of astigmatism that you can have. Cylindrical lenses that are used to correct astigmatic errors not only have a power value, but they also have an axis value, i.e. you should know where this cylinder has to be placed on the cornea. Remember, you have a vertical meridian and a horizontal meridian, and you can place the cylinder along the horizontal or vertical meridian depending upon which of the two meridians is corrected by the cylinder. So that is what the axis of the cylinder specifies. So if I bring this rather nice axis chart for the cornea, and then I'll bring the meridians. So this is the X meridian, this blue line, and the red line is the Y meridian or the vertical meridian, and the blue line is the horizontal meridian or the axis. Let's assume that the horizontal meridian, the blue line, is more curved, and the vertical meridian, the red line, is relatively less curved. The two meridians are usually at 90 degrees to one another, plus minus 20 degrees. But they can be aligned to any one of these corneal angles. So in this picture right now, the vertical meridian is aligned to 90 degrees on the cornea, and the horizontal meridian is aligned to 0 degrees on the cornea, or 180 degrees, it's the same thing. But they are at 90 degrees to one another. But let me give you another scenario. So this is the flat meridian, and this is the curved meridian. We are correcting the flat meridian by a sphere and a curved meridian by a cylinder, and the cylinder is placed at 0 or 180 degrees, because remember, we need to specify which of the two meridians the cylinder is going to act on. Because remember, cylinders only act in one direction. So because we are correcting the curved meridian with our cylinder, we need to specify its axis value as well. But what if the two meridians of the cornea were not at 90 or at 0 or 180? What if they were aligned to the 80 degrees on the cornea and 170 degrees on the cornea? Because that is possible. These two meridians can be aligned to any of the degrees on the cornea. They are usually at 90 degrees plus minus 20 degrees to each other. That means that the vertical and the horizontal meridian would have an angle of 90 degrees plus minus 20 degrees to each other. Right now I am showing them as 90 degrees. So this little box here in the white shows that these two meridians are at right angles to one another. But it is possible that they are somewhere between 70 and 110 degrees, 90 minus 20 and 90 plus 20. So that is the relations between the curved, the vertical and the horizontal meridians, but they can be aligned to any of the corneal angles. So the first one was aligned to 90 and 180 or 0. The second patient has the same two meridians, one flat and one curved, but rather than being aligned to 90 and 0 or 180 on the cornea, this time they are aligned to 80 and 170. They are at 90 degrees to one another, but they are not aligned to 90 and 180 on the cornea. They are aligned to 80 and 170 on the cornea, and that is possible. That is why we need to specify the axis value of the cylinder, because the person who is going to be making the spectacles, the optician, should know where the cylindrical lens has to be aligned so as to produce a stigmatic or a single image. So a cylinder has an axis value, a cylindrical lens has an axis value in addition to a power value. So let's recap astigmatism. It occurs when your cornea is rugby ball shaped, i.e. an oval, It can be of simple or compound, mixed or hypermetropic types, myopic and hypermetropic type, and can also be a mixed type. And furthermore, is corrected using a cylindrical lens, maybe in a combination with spherical lens, as we saw in two of the five possibilities or the types of astigmatism. You only need a cylindrical lens, the simple myopic and simple hypermetropic astigmatisms. You would need a cylindrical and a spherical lens in compound hyperopic, compound myopic, as well as a mixed astigmatism types. The cylindrical lens has a power as well as an axis value, as we have just seen. Let's see how all of these patients with distant refractive errors or ametropia present. So the clinical presentation in both adults and children, verbal children who can communicate themselves, would be gradual painless loss of vision in one eye or both eyes, and this visual loss is loss of visual acuity. If they're already wearing spectacles, they would know that they have a refractive error. It's just that the refractive error might have changed so that the spectacles are not working as well as they did, or they just wanted to see if the refractive error has changed at all. Distant refractive errors usually manifest ametropia. Remember, that is what distant refractive errors are. They usually manifest in pediatric age group, with the possible exception of hypermetropia, which is initially masked. The reason that this happens is because, remember, you have myopia or hypermetropia or even astigmatism because the curvature, power, and the length are not what they're supposed to be. And this is something that is usually what is there since the very beginning, the point of the formation of the eye, and if there is something wrong with the mechanism in which something is formed, so that is going to be around since a very young age. So most of the time, these refractive errors have been around are usually found in a pediatric age group. Again, I am saying usually manifest in a pediatric age group. It is possible they manifest later. For example, when puberty comes along and you have this growth spurt, the eyeball might become longer than it was before. So you might get myopia a little later in life. As I said, medicine, there is nothing always. There is nothing absolute. They're all Jedis. They think along various grays. They don't think in absolutes like Sith do. So usually these refractive errors do present in a pediatric age group, with the possible exception of hypermetropia. But again, this is usually, it is possible that they present later as well. Astigmatic errors present as the patient misreading letters during Snell's visual acuity assessment. And that is because the 2-point foci actually confuses the patient as to what is written. So they might read an O as a P and so on and so forth. The magnitude of the refractive error between the two eyes can also differ, which is called anisometropia. An meaning not, iso meaning same, met meaning measure, opia meaning vision. And many of the patients would come and say, if I squeeze my eyes, I can actually make things better, which is producing a pinhole effect. And if they are of that age, they might have concurrent near vision issues. So they can have a distant refractive error as well as a near refractive error, i.e. a mixed type, which is pretty much understandable and is a function of age. The problem or the real challenge are pre-verbal children and pre-literate children also, because it's very difficult for them to describe their errors because they can't talk. It's the parent or the guardian that says, look, they don't recognize familiar faces, and the most familiar face is the face of a mother. They seem to be searching for lights. They seem to be bumping into furniture or objects. So these are the clues that the guardians or the parents are going to get as to that something is wrong with the vision. And to assess visual acuity in pre-verbals is also a challenge because they can't read the Snell's chart, so you can't use that. They haven't even started to talk, so you can't show them pictures and ask them to match what they've been shown or to recognize what they've been shown. So one test is called a box candy bead test. Bok, the person. And what he does is, and they're specially designed candy beans, but you can use any small candy that you get. And what you do it, you place it about 40 centimeters from the child and you ask the child to pick it up. If the child can pick it up, that would mean that the child has at least 660 vision. So this is one way of assessing visual acuity in children. It's not the easiest way to do it, but it is possible to assess visual acuity using the box candy bean test. Other features that are associated with the refractive error is watering. That's simply because you're rubbing the eye because you want to get a clear vision, which causes reflex watering, and headaches. Of all the refractive errors that we have talked about, presbyopia and ametropia, distant refractive errors, we haven't ever talked about the role of trigeminal nerve, which is actually the nerve that is responsible for carrying the sensation of headache. So where is this headache coming from? There is no headache with refractive errors. It's a discomfort, and this discomfort is coming either because you're squinting too much, and that's muscles acting, contracting for too long, or hypermetropes who are using accommodative effort for prolonged periods because they're using accommodation all time. They're using their eyes for distance as well as near, so that it is basically your muscles of your ciliary body that are getting tired and producing this discomfort. So it's more of a discomfort, less of a headache that's associated with refractive errors. Nothing to do with headaches. Believe me, no matter what neurologists or neurosurgeons say, there is no headache in a refractive error. It's a discomfort, yes, I agree, but not a true headache. So let's not call it a headache. Patients do say it's a headache, but it's more of a discomfort than a headache. Headache is a very specific term, and words have meanings. So just in case you did not hear what I was saying and just had your eyes open and your ears closed, or you were probably listening to music, I've put this line down here that a bean picked up by a child at 40 centimeters implies 660 visual acuity. I did actually say it, so I've also written it just to make sure that it's written. So you can say not only was it audible, it was also viewable or visible, whatever. So distant refractive errors, just like presbyopic errors, can be corrected, they can't be cured. And all of the methods that I'm going to list are valid except for number one. Just like increasing a distance in presbyopia, increasing the distance of the near object in presbyopia is not a method of correcting presbyopia. Squinting is not an appropriate method of correcting distant refractive errors. It is not a specific method to correct ametropia. I put it down here because patients tend to do it themselves. This is not a dispensing method. It is not a prescribing method. It is just put up here to complete the discussion of distant refractive errors. Spectacles is the most common method, the safest and the most oldest method. You can use contact lenses, connective lenses. Contact lenses is an alternate to spectacles, and the benefit is of weight and comparatively better field of view because they are flush against your cornea. Lasers is a modern way of correcting most refractive errors. Again, you require careful patient selection. We'll just talk about that briefly as well. And we'll start off by talking about squinting. So refractive errors of up to 5 diopters, either myopia or 5 diopters of myopia or hypermetropia, can be overcome by squinting. And what squinting does is create a pinhole effect. A pinhole effect only allows light rays that are close to the optical center of the cornea and the lens to pass through. And light rays that are passing through the optical center are considered to be automatically or already focused. They do not have to go under the process of refraction in order to attain a focus. They are automatically focused. This is an optical principle. You can go back and refer to your book of optics that you did in school to read more about this principle of pinhole and pinhole camera. It works exactly like a pinhole camera did. So light rays that are passing through optical centers, or more appropriately nodal points of the cornea and the lens, would pass on undeviated, unrefracted, and focus on the cornea, and that is how a pinhole works. The problem with a pinhole is it restricts your vision significantly because you're only allowing central pencil of light rays to pass through. And this is again not an appropriate method of managing refractive errors. It's a method by which individuals correct the refractive errors by themselves, just like increasing the distance in presbyopia was. So don't prescribe this, don't write this, don't mention this in the OSCE, putting it here to complete the discussion. The first proper way of correcting distant refractive error is use of spectacles. It's the easiest and the most common way. They can correct all type of errors. The weight can be an issue because the greater the magnitude, the greater the weight of the lens. You can use high density lenses, which are called higher optical density lenses, high index lenses, but again they would have some weight and they can sort of impinge on the nose or even produce a little bit of a blemish on the nose. And again, those, if you are involved in a physical sport or an activity, again, spectacles could be a hindrance. You can use specially designed sports eyewear, which is made from shatterproof lenses, or you can switch to contact lens. Contact lenses are better in as compared to spectacles because they provide better field of view because they are flush against the cornea, and they also provide better visual fidelity again because they are flush against the cornea, and they weigh less. They do require appropriate caring and cleansing, and they can cause allergic reactions. But there are of various types. So if you are allergic to one type, maybe the other type is suitable, and sometimes it's the washing liquid or the cleansing fluid that is causing the problem. So changing that can also help. We'll talk about more allergic reactions associated with contact lenses when we talk about conjunctivitis. There are various types of contact lenses: soft contact lens and RGP, rigid gas permeable lenses. These are the two most common types. The most common type among these two is the soft contact lens, which is used to correct almost most of the spherical and astigmatic errors. They are usually prescribed to adults and children of greater than 12 years of age, with the exception that children who undergo cataract surgery at less than 2 years may be prescribed contact lenses for the duration of time that an IOL or intraocular lens can't be implanted. We'll talk more about this when we talk about cataracts, which is the next discussion topic. A rigid gas permeable lens is used for extremes of astigmatism as seen in keratoconus. We'll talk more about keratoconus when we talk about conjunctivitis. The rigidity of these lenses forces the cornea to adapt its curvature according to the curvature of the lens, so thus negating or reducing astigmatism. Soft contact lenses can be made up of various materials and would thus have different types of variability. Wearability. Sorry. So you can have daily wear lenses, which you wear every day, extended wear, which you can use for an extended period of time, and disposable types, which could be daily or monthly disposable. For an undergraduate, really, this is something that is not a required competence, even not for most ophthalmologists, because this is the job of a contact lens dispenser or an optician. You can tell your patients that even as a general practitioner that there are various types, and your optician can tell you more depending upon what is suitable for you. So these are what rigid contact lenses look like. This is what a soft contact lens looks like. It's called soft because it's flimsy. It can even fold, and I'm sure those of you who have worn contact lenses have worn the soft types. If any of you have used a rigid contact lens, that would imply you have a significant amount of astigmatism that can't be overcome by a soft contact lens, which implies that you probably, but not always, have keratoconus. A soft contact lens is called a soft contact lens because it's soft and it's flimsy and foldable and it's sort of bendable, malleable. Lasers. Everybody wants to get laser surgery done. So what we can do is use laser surgery to reshape the cornea to overcome the refractive error. The effect produced by the laser is called photoablation, and that is like removing tissues in layers. The laser types used to correct refractive errors are excimer laser, which is a contraction of excited dimers, and a femtosecond laser. And the laser procedures are these four: photorefractive keratectomy, or PRK, which is the oldest procedure; laser in situ keratom mallucis, or LASIK, which is the common procedure done these days; laser intraepithelial keratom mallucis; and then finally small incision lenticular extraction, SMILE, which is now gaining ground. Each of these methods is, again, as I said, reshapes the cornea to overcome the refractive error. And as I said, you need to have a very good criteria for patient selection. I'm going to just very briefly give you the criteria and also the justification for it. You need to have the patient's age above 20 years, or at the least 18. 20 is safer, to have some stability of the refractive error. Remember, a laser is just reshaping the cornea. If the refractive error has to increase because the eyeball's length is still changing, it would happen even after you get laser surgery done. So for stability's sake, age over 20 or at least 18 is first parameter. Refractive error has to be stable for 18 months or more. Again, the same reason I just described. The cornea must have adequate thickness. If you want to reshape the cornea must be thick enough to, tolerate the effect of the laser. Or stand the effect of the laser. If the cornea is too thin and you do laser, the cornea might lose its shape, so you might end up in a worse situation than you actually began with. The refractive error has to be in the range of the procedure that you have selected. We'll show you next. You shouldn't have any eye infection. That goes without saying, because it can produce artifacts and determination of the refractive error as well as its laser correction. It shouldn't have dry eyes, because dry eyes is something that can worsen after laser refractive correction because it affects tear film stability. We'll talk more about tear film stability when we talk about dry eyes. So these are the three laser types. We are not going to talk about intraepithelial keratomileusis, laser intraepithelial keratomileusis. It sort of never took off or gained the same level of popularity here in our region as PRK, LASIK, and SMILE have. PRK was a first generation procedure, and what you did was you applied laser to the direct corneal surface, which did reshape the cornea to overcome the refractive error. This was its limit, myopia of -6 diopters and some degree of astigmatism. The problem was corneal superficial surface has a lot of free nerve endings. So when you do laser like this, you expose those free nerve endings and the patient experiences quite a lot of pain. So visual recovery is delayed by up to 4 or 5 days. To overcome that, the second generation procedure, LASIK, came into existence or popularity. And what LASIK does is you'd raise a little bit of a flap of cornea, apply laser to the corneal stroma, and you can put the flap back. It has the advantage of not damaging those free nerve endings, so your visual recovery is much faster. It is something that if you get it done in the morning, by evening you are good to go. It can correct a lot of myopia, limited degree of hypermetropia, and also greater degree of astigmatism than PRK did. SMILE, small incision lenticule extraction, is a procedure in which you don't create a flap. You create a little tunnel. You create a lenticule of corneal tissue by laser, and you remove that lenticule to correct the refractive error or reshape the cornea. It can correct significant amounts of myopia and astigmatism. This is the most minimal surgery because you're not creating a flap. It's just a little bit of tunnel through which you can remove the corneal lenticule. Lenticule is that little bit of tissue that you're removing by reshaping the cornea in order to overcome the refractive error. All three of these procedures can be done here locally in our city as well as in other cities of Pakistan. And as I talked about before, way long time ago in a galaxy far away, when we were talking about presbyopia, and we talked about contact lenses as a method of correcting presbyopia, it is possible to correct distant and near refractive errors simultaneously. And we can use spectacles, either of the bifocal or progressive types, which work for near and far distances. We can use multifocal or varifocal contact lenses, which work for near, intermediate, and far distances. And we can also use presby-LASIK. We talked about presby-LASIK when we talked about correction of presbyopia. So spectacles can be bifocals, and they're easily identified because the near portion is stuck onto the lens and you have a clear lines which shows you which portion is for near. I'm sure you have seen or have individuals in your house who use these types of spectacles, in which the distant portion is the top portion, the reading portion is at the bottom because you look down to read, so you're looking down through this bottom portion. Progressive addition is a modern take on bifocals. Rather than having another segment stuck on the lens, the glass or the lens within the spectacles is curved as such so as to focus light from various distances, distance, intermediate, and near. So as you look down, there is no division in the glass. The glass is curved in a way so as to provide good distant vision, intermediate, and near vision. Takes a little bit of getting used to, but once you get used to them, progressives are very good if you want to correct both distance and near vision. These are various types of multifocal contact lenses that correct distance and near refractive errors together. You really don't need to know their names. If you do, that's good. But you need to know that yes, contact lenses can be used to correct distance and near errors at the same time or simultaneously. Presby-LASIK we've already talked about. It creates a multifocal cornea to allow light from various sources to focus on the retina. I'm not going to go into detail. If you really want to know and you've forgotten already, you can just go back to the presbyopia discussion, which was, I think, about half an hour ago, and just review it. Now we are going to be talking about qualifying and quantifying refractive errors. We have talked about all the refractive errors, the distance error and the near error. Now we are going to talk about how do we determine how much and what type of error is present. Remember, visual acuity gives you no clue. A history gives you a little bit of clue, but as we have talked about before, to determine magnitude and type of refractive error, we need to use a retinoscope or an autorefractor for ametropia, distant refractive errors. For near refractive error, things are much simpler because all you need is a reading chart, and you can do an age-based correction or just fill up the accommodative amplitude deficit. Distant vision errors are qualified, i.e. hypermetropic, myopic, or astigmatic, and quantified, i.e. putting a number next to those errors by using specific instrumentations. We have already talked about the names of those instruments as a retinoscope and an autorefractor or an autorefractor keratometer. And or the use of medications. We've also discussed this medication, i.e. the cycloplegic drug, when we were talking about hypermetropia and more specifically latent hypermetropia. Performing visual acuity does not tell you about the type or magnitude of refractive error. Visual acuity only tells you about the presence of a refractive error. History can give you a very good idea, but can again not diagnose a refractive error. For example, early onset presbyopia may alert you to hypermetropia. Age is again something that can alert. Remember, most of the time, myopic errors are caught early. So they're just giving you ideas, but not a definitive diagnosis. Near vision, on the other hand, as compared to distant vision, is it's easier, simply because you have a patient of a specific age group with a very specific problem. Again, you need to ensure that what you are looking at is a near vision error and not a latent hypermetropia. So your age and your symptoms must be appropriate for a near vision error. Don't confuse latent hypermetropia as a near vision error. A young patient who is generally not of a presbyopic age complaining of a near vision issue is likely to be a latent hypermetrope and not a presbyope. We've talked about that in detail when we were talking about hypermetropia. So you can go refer back to that discussion if you want to recall or review what we talked about. So let's talk about the instruments first, and we'll talk about the drug. The retinoscope is a manual instrument that determines a refractive error. It is used mostly in children and those with special needs. In modern times, we don't generally use retinoscopes as much as we used to. The thing to remember is retinoscope is not used to examine the retina, although it's called a retinoscope. That's the job of the ophthalmoscope. A retinoscope is used to figure out a refractive error. I know it's crazy, but it is what it is. An autorefractor and an autorefractor keratometer are automated machines that determine the type and the magnitude of distant refractive errors. They are the most common ways of doing this. Autorefractors only measure refractive errors. Autorefractor keratometer also measure corneal curvatures, which can give you an idea about astigmatism and, more importantly, give you important values for calculating intraocular lens power for cataract surgery. So we'll talk more about the keratometric function when we talk about cataract surgery in the next discussion. The use of retinoscope or these automated machines is also sometimes referred to as objective refraction, because they give you the type and magnitude of refractive error without the patient telling you anything. So they are objectively giving you a refraction or what lenses to use in order to correct the refractive error. However, this, irrespective of how good your instrument is just a guide. These numbers are not 100% accurate. In order to fine-tune this and to come up with a final prescription, we use something called the trial box. I'll show you these pictures just in a second. And that is called subjective refraction. So you do objective refraction, you use a trial box, do subjective refraction, and then hand over the prescription card to a patient. Don't do it. Many times when you go to an optician, they just use the computer and they say, yeah, this is your correction, and they give you spectacles. 6 out of 10 times it'll work. 4 out of 10 times it won't, because that's not the proper way. You need to make sure that whatever reading the machine is giving you, the objective refraction is something that the patient actually accepts, which is the subjective refraction. It doesn't really take that long, and it completes the procedure, because in the end, it's not what the machine says it's good, it's what the patient feels and says, yeah, this is the best vision I have with these set of corrections. So subjective refraction is sort of important. And it should be obvious that subjective refraction can't be done in pre-verbal patients because they can't respond to you. And it can also be not done in patients who cannot tell you about their visual status. Special individuals, those who have trouble communicating, will not be able to, benefit from subjective refraction. So the process for them stops at objective refraction, which is the best that can be done. So this is something that can be kept in mind. I'm just putting here to here because somebody might ask you this, and you might be doing subjective refraction in pre-verbals without thinking, what are they going to tell you? They can't tell you anything. So it's not done in pre-verbals or those without any appropriate way of communicating their visual status. So this video will show you how an autorefractor keratometer works. We have a bigger video. It's in the learning resources. You can refer to that video if you want to see the entire video. When the patient has properly positioned his chin and headrest, we can move the machine using the joystick, focus on the eye, and when the eye is focused, the machine automatically starts to take a reading. And it has done one eye, and we can move it to the other eye. it has taken the reading of the other eye. Now, and this machine will now has quantified whatever refractive status that the patient has. Now we'll talk about how objective refraction is converted into a prescription for the patient that he or she can take to an optician for dispensing spectacles or contacts. So this is the objective refraction data from the autorefractor or autorefractor keratometer. And remember, we said it provides objective refraction, which is a very good guide. This information is used to do subjective refraction using a trial box. A trial box is a set of loose lenses which can be placed into this frame which the patient wears, and we can use these lenses and see what the patient prefers. Remember, this objective refraction is not accurate 100% all of the time. So maybe in 8 out of 10 patients it is accurate 100%, but in the 2 it's not, so you don't want to be a statistic. Do a subjective refraction, and this subjective refraction allows the person doing the refraction to create this spectacle prescription card for the patient, and the patient takes this to the optician. And as you can see, there is a little bit of difference between what the objective refraction was and what the prescription is, because this prescription is based on subjective refraction, what the patient actually preferred or liked. So the cylinder in the right eye is reduced slightly. The sphere and the cylinder are increased slightly in the left eye, and the axis is also adjusted a little bit in the right eye, because this is what the patient preferred. And it is the patient preference that matters the most, because he's sitting there telling you, yeah, this I can read better with this. And the machine is a good guide, but this subjective refraction is something that must be done so that you are sure that whatever you're prescribing to the patient is satisfied with it. And IPD, or interpupillary distance, must be mentioned as it is here. The goal is to satisfy the patient and not follow the machine data blindly. Do not follow the machines blindly. You know what happens if you follow machines blindly. iRobot, the Matrix. Okay, so the differences are highlighted, as we've already talked about these. We have talked about instrumentation. Now we'll talk about medication, specifically cycloplegic agents. And cycloplegic agents are indicated in all patients of suspected latent hypermetropia, because this is the only way to neutralize the effect of accommodation on hypermetropia. It's also indicated in all children, usually up to 10 to 12 years of age, and it can also be considered in older children as well. And in children, it is always indicated simply because children have a lot of accommodative reserve, a lot of accommodative amplitude. They can mask near as well as distant vision errors. So if you have a child who has very vague symptoms of headaches or discomfort, you know how discomfort is misconstrued as a headache in the domain of refractive errors. So if a child comes to you with the parents complaining, he keeps complaining of headaches, and the vision is 6/6, you still need to make sure, and the near vision is also fine, which it should be in children anyways. And it can simply be because the child has so much accommodative reserve that he is using accommodation not only for near vision as he should or she should, he's also using or she's also using it to correct distant vision. And both of them are masked simply because there's a lot of accommodative amplitude available. But because the ciliary muscle is always working for distance and near, that would produce a discomfort which can be thought of or considered a headache by the child. So that is why in children between 10 to 12 years of age, and maybe sometimes older, a cycloplegic refraction or cycloplegic objective refraction is always indicated. The medication that is used is cyclopentolate, and it has advantages over other medication. The other medication are tropicamide and atropine. Over tropicamide, it has the added advantage that it works really well on ciliary muscle as compared to tropicamide, which has a weaker action. As compared to atropine, it has a limited duration of action of about 24 hours. Atropine's action can last up to 2 weeks. So the way to use it is to put 1 drop 4 times every 15 minutes. Do your objective refraction with automated refractor or retinoscope. One of the side effects of using a parasympathetic drug is that it also dilates the pupil, which allows so much light to enter the eye that you cannot take a proper visual acuity. So a subjective refraction is usually delayed by a couple of days after objective cycloplegic refraction so that the pupil can come back to the normal size. And as we have already discussed before, subjective refraction can be done in pre-verbal patients or in patients who have no appropriate way of communicating their visual status. So obviously we're going to skip this step in those patients. and just rely on objective refraction, use objective refraction to create a prescription for the patient. Let's talk about near vision. Near vision is very simple. Qualifying near vision is ensuring that what you're looking at is a true presbyopia and not a latent hypermetropia, which is by the age and presenting complaint. If you suspect latent hypermetropia, do a cycloplegic refraction using cyclopentolate, as we just discussed. One thing that you must always realize is that a near vision error is corrected after correcting a distant vision error if one exists. Simply because when we were talking about near vision errors, we were talking about accommodative amplitude, increasing the power of the eye from 60 diopters. So if the power of the eye is not 60 diopters, i.e. the patient has a distant refractive error or is ametropic, then you can't appropriately correct a near vision error because the assumption is the power of the eye is 60 diopters. So a distant vision error is always corrected before correcting a near vision error if a distant vision error occurs. And that is the reason why. So how is the refractive error corrected? I'll show you a nice infographic for this. So you have a history. Hey, I'm here because I have gradual painless loss of vision, blah, blah, blah. Let's do your visual acuity. And you do a visual acuity. If it's not appropriate, 6.6, then we use, and obviously when you are doing visual acuity and the patient is already using spectacles, you ask him to put on spectacles. No use doing visual acuity when you know that the patient has spectacles and you don't make him wear the spectacles because the vision would never be 6.6. So make him wear the spectacles, use a pinhole if the vision is not 6.6. And if you have a baby, use one of these bean tests and the vision is at least 660 if the child can pick up a bean at 40 centimeters. Remember, I added this statement because if you weren't listening, you could at least see. And if this is the vision and with pinhole it improves to 6.6, that means you are looking at a refractive error in all likelihood. So we move forward. Doing this test, just the visual acuity, is not telling you the type of error or magnitude of error. It only tells you that refractive error is a possible cause of this decreased vision because the pinhole is improving your vision, and pinhole improving a vision points to possibility, yeah, this is a refractive error causing decrease in vision. Look at the visual acuity clinical scales for more information. So step 3 would be to do an objective refraction using either a retinoscope or a automated machine. You might want to use a cycloplegic refraction for children who are younger than 10 to 12 years of age, suspected latent hypermetropes, and you need to wait 1 to 2 days before moving on to the next step because it dilates the pupil. We just discussed this a couple of slides ago. So you have your objective refraction data, you do your subjective refraction using a trial box and using lenses from the trial box with the patient. Patient gives you thumbs up, thumbs down, keep on adjusting. And once you have done that, reassess vision. Obviously distant and or near if required, then give him a spectacle prescription card like this so that he can go to an optician's shop and get his spectacles dispensed or her spectacles dispensed. So this is an infographic, nice infographic that is telling you how a refractive error is corrected. And it goes without saying that we'll need to skip steps 4 and 5 in patients who are either pre-verbal or have no effective way of communicating their visual status. In these patients, what we do is we do step 3, do our objective refraction with or without cycloplegic refraction as the case may be, then use our clinical competence, years of training, and create a prescription for the patient, which can then be used to dispense spectacles. So far, we've been talking about and looking at the magnitude of refractive errors. So I'll take you a slide back. This printout from the autorefractor objective refraction, and even this spectacle prescription is just giving you the magnitude of error. This does not write what is the type of refractive error. Type of refractive error is not written on the spectacle prescription either. And at times, it is important to know the type of refractive error because the patient might ask, hey, what do I have? And you need to tell him you have this, or you need to understand for yourself what type of refractive error the patient has. So let's see how this is done. In order to figure out the type of refractive error, we need to deconstruct spectacle prescriptions. And that is important. Let's look at this prescription. And we have a patient who is anisometropic, has refractive error in one eye, the other eye is fine. You can go back and look at patient presentation of distant refractive errors where we defined anisometropia. So it has a sphere of +3, a cylinder of -1, and an axis of 90 degrees. And on the face of it, this looks like mixed astigmatism. Looks like mixed astigmatism because we have a plus sphere and a minus cylinder. So we are using two different lenses of opposing signs, which probably implies this is mixed astigmatism. This is misleading. I'm telling you right now, this is not mixed astigmatism. So what is it? We need to deconstruct this prescription in order to figure out the type. And deconstruct means let's remove these lenses to see where the original foci were, which would tell us what type of a refractive error it was. Let's remove the cylinder, because removing the cylinder is easier. Cylinder only is going to disturb one of the meridians, so we'll remove the cylinder. And this focus, the more curved focus, comes in the front of the retina. Why is it coming in the front of the retina? The cylinder had a minus power. That means it was reducing the power in this meridian. If it is reducing the power in this meridian, it meant that if this with a -1 lens focuses on the retina, without the -1 lens, this meridian had more power. We are subtracting power from this meridian to focus it on the retina. So without this correction, this focus had more than 60 diopters of power. If it has more than 60 diopters of power, it focuses in front of the retina. So this is a myopic focus. So this focus, which was corrected by -1, was originally here. Let's remove the sphere and see the magic happen. The problem with spheres is it not only acts in one direction, it will act in vertical as well as horizontal direction. Remember, the cylinders act only in one axis, whereas spheres will converge or diverge light irrespective of which axis the light is coming in from. So let's remove this sphere. It is obviously going to change the flat focus, and from the retina, because the sphere was adding power to the eye, once we release this, the eye would obviously lose power in the flat meridian. So originally this focus was behind the retina. The +3 lens was adding power to this. This is just part of the story, because when we talk about spheres, all light rays passing through the spherical lens were refracted, including in the curved meridian. So not only is this going to feel the effect of +3, so is this meridian going to feel the effect of +3. So where is this going to go? It's very simple. Simply add +3 to this focus, which is -1. So -1 plus 3 is +2. So this is where the original focus was in this patient. So both the foci were behind the retina. This is not mixed astigmatism. This is compound hypermetropic astigmatism. And this is how we deconstruct a prescription into a type. And I'll show you the rules in the next slide, which would make things even simpler because you just need to remember the rules. So what seemed like mixed astigmatism turned out to be compound hyperopic or hypermetropic astigmatism, simply because of the effect of the sphere, which affects light rays passing through all the meridians. See, it's not all that easy. Remember, I said there are only a couple of things that are tricky. Latent hypermetropia was one. This is the other. Everything else is simple, as we've been doing. It's really simple. So let's construct this back. Let's test our assumption. Let's test our deconstruction. Let's put the lenses back, and first we will put back a sphere because we removed it last. It will move one of the meridians back onto the retina because this was +3 behind. With +3 it comes here. This, obviously the other meridian is also going to be affected because spherical lenses affect all meridians. It will come into this position -1 because right now it is at +2. And now it is going to come here because this is right now sitting at 58. By adding 3, we are bringing it into 61. And now we need to push this meridian back by using a cylindrical lens. We don't want to use another sphere because it will disturb the first focus, the flat focus. So we use a cylindrical lens, it goes back. So now we have constructed our prescription back from the deconstruction that we had. So our deconstruction was right. So these are the steps that are involved, and you will also use when you're solving the questions that will be presented to you in the next few slides. So to determine the type of astigmatic error, what you do in step 1 is, for the type of refractive error in one meridian, look at the sign of the sphere, and that is the error in one meridian, any meridian. For the other meridian, in order to determine the type of refractive error, take the sign of the sum of power of sphere and power of cylinder. In the example that we did before, the power of sphere was +3, the power of cylinder is -1, so +3 minus 1 is +2. So the sign is plus again. So that means that in the case that we just saw, we were looking at compound hypermetropic astigmatism because the sign of the sphere was positive and the sign of the sum is also positive. So the error in both of the meridian was a positive error, thus compound hypermetropic astigmatism. If you come up with 0 in step 2, the patient only has a simple astigmatic error, either hyperopic and myopic. And if it was myopic, the sign of the sphere would be negative. If it were hyperopic, the sign of the sphere would be positive. And this is only for astigmatic errors. For spherical errors, things are very easy. If it's minus sphere, it's a myopic error. If it's plus sphere and written next to distance, it's hypermetropia. If it's written next to near, it's presbyopia. Pretty simple. So before I go on and give you those questions, let's just do one worked example. This is the prescription and these are the right and left cornea, and both of them are represented by a rugby ball or an oval because we are obviously deconstructing astigmatic prescriptions. So for the type of astigmatic error, rule number 1 or step number 1 was the type of refractive error in one meridian equals the sign of power of sphere. So in the right eye, the sign of power of sphere is negative, and we can place it in any one of these two meridians, either the X or Y meridian or vertical or horizontal meridian or whatever you want to call them. So we can place it along the vertical meridian or we can place it along the horizontal meridian. It really does not matter. So let's just place it along the horizontal meridian and move on to step 2, which is type of refractive error in the other meridian, which is going to be the vertical in this case, is the sign of sum of power of sphere and power of cylinder. Now we are doing the right eye, so let's add these two together. The sphere is -2, let's bring it here, and we are going to add the power of cylinder to it, which is +1, and this is obviously algebraic addition, and we are going to end up with -1. So the type of refractive error in the other meridian is the sign of sum of. So the sign of sum of power is again minus, and we are going to put it along the vertical meridian. This means that in the horizontal and vertical meridians, the type of refractive errors were both of the myopic type or negative. And this then becomes a compound myopic astigmatism. Rule number 3 is not applicable because the sum is not 0. Let's do the other eye. And again, step 1 is the type of refractive error in one meridian is the sign of sphere, is the sign of power of sphere, which is in this case is plus. So we're going to go put plus along the vertical meridian. As I said, you can put it along the vertical or the horizontal or X or Y meridian, no matter what you want to call it. It doesn't really matter. Just put it in any one of the meridians. And for the other meridians, we are going to add the sphere and the cylinder. So that's +1 sphere in case of left eye, and the cylinder is -0.5. And when we add these two up, we end up with +0.5. So the sign of the sum is plus, and we're going to put plus next to the other meridian, which in this case is the horizontal meridian. Now the signs in the vertical and horizontal meridian are both plus. That means the type of refractive error in both the meridian is of the hypermetropic type, and this makes it a compound hyperopic astigmatism. Again, rule number 3 is not applicable because the sum wasn't 0. Now if you look at the prescription on the face of it, the right eye seems to be mixed while the left eye also seems to be mixed, but this is not really the case. In both cases, we have a compound astigmatism in the right eye myopic type, in the left eye hypermetropic type. And as we've already discussed, this is because of the effect of the sphere. So now you can do those questions that I'm going to show to you and just follow these rules that we just did in this worked example. So these are questions for your solving pleasure. There's going to be a key at the end, so you can refer to the key, but please try and solve them on your own. So what I want you to do is to determine the type of refractive error as shown by these prescriptions. In both eyes, obviously. And now we're going to talk about how to determine the power of spectacle lenses once they've been dispensed. Maybe the patient wants to check if they've been properly dispensed or if their power is really what was prescribed to him or her. And this is done by using something called a lens meter. Lens meters are automated on manual devices, But obviously not everybody is going to have a lens meter, especially if you are a family physician and you're training to be a family physician. And still you can do something really simple. Use the lenses and read some text. If it is magnifying the text, it's a plus lens. So you're looking at hypermetropia if it's for distance, presbyopia if you're looking for near. If the lenses minify things, it's a concave lens and you're looking at myopia. You can also move the spectacle over the written text. If the direction of the text and the lens movement are the same, that means you're looking at a minus lens. If the direction of movement of the lens and the movement of the text through the lens are opposite, you're looking at a convex lens. I'll put some videos in as well so that it sort of becomes easier for you to understand what I am talking about. So these are manual and automated type of lens meters. What follows are going to be videos showing you how text moves as you look through the lenses in order to figure out you're looking at a plus lens or a minus lens. Spectacles with convex lenses or plus lenses, those that are used in case of hypermetropia, presbyopia, produce an against movement. So when you're moving the spectacles in one direction, the text seems to move in the opposite direction, the text that you're looking through the lens of the spectacle. So if the spectacles are moving to the right, the text seems to move to the left, and vice versa. When we see the same text through a concave lens, the text moves in the same direction as the movement of the spectacles. And obviously you're looking through the lens that's in the spectacle. So let's see this. The spectacle moves to one direction and the text seems to move in the same direction. So if the spectacle is moving to the right, the text seems to move to the right. And if the spectacle moves to the left, the text seems to move to the left. So in addition to magnifying and minifying, magnification for convex lenses, minification for concave, the other way to check if the spectacle has a plus or a minus lens is to move the lens over a piece of anything and look at how the image that's being produced moves. For convex lenses, the movement is in the opposite direction to the movement of the spectacle. For concave lenses, the movement of the text or the image is in the same direction as the movement of the spectacle. Our journey is nearly at its end. We started off by talking about refraction in lenses, moved on to the optics of the eye, the reduced eye, then the errors of refraction, presbyopia, distant refractive errors. Then we figured out how do we quantify and qualify refractive errors. We can use either a manual retinoscope, which is not that much used, automated instruments in the form of automated refractors or automated refractogrammeters. Then we also figured out how do we actually create a spectacle prescription. How can we learn what sort of a refractive error the patient had by looking at a prescription. And then finally, the last things that we are going to talk about are anisometropia and amblyopia, two very interesting and very important topics. These are the two last things that we do, nearly the last. Let's take these two eyes. These are two normal eyes and which have no refractive error and thus no anisometropia. Anisometropia was when there was a difference in the number between the two eyes, i.e. the refractive error between the two eyes was different. So they are all, both of these eyes are looking at the teddy bear, which is our object of interest. So the light from the teddy is focused onto the fovea, and each of these eyes is going to produce a clear image on the retina because this patient is emetropic. And this would then travel through the central visual pathways all the way to the visual cortex, where the visual cortex would fuse these two images into a single image, a clear image that this person would see. Nice, normal. Let's see what happens if this eye has no refractive error, the eye at the top, the right eye. The bottom eye has an uncorrected refractive error of plus 1.5. And this is a distance refractive error. So what happens is we have anisometropia because there is a difference of greater than 1 diopter. That was what anisometropia is technically defined as, difference of greater than 1 diopter of error between the two eyes. And now they are both looking at this teddy. One eye produces a clear image. In the other eye, the image is produced behind the retina. Now you would say, hey doc, you said if you have a blurred image, you get the process of accommodation to start, which focuses this image back on the retina. You would be right, I did say that. But do you notice that the image on the right eye, the eye at the top, is already focused? The eye does not need to accommodate because the signal going all the way back to the visual cortex from one of the eyes is the image is clear and it does not need accommodation. So the process of accommodation here will not start simply because one of the eyes is generating a nice clean image and the other eye is not generating a nice clean image. So the visual system won't compromise a clear image over an unclear image because you already have something that's nice and focused. Why would you want to spoil that? So one clear image and one blurry image on the retina, no involuntary accommodation because we have one clear image. Now both of these are going to go through the visual pathway to the visual cortex, and the visual cortex can't combine these two images into one another because they don't appear similar. One is clear, one is blurry. So what the visual cortex would do over time is it will only start considering the clear image, and over time, slowly, it would shut down the blurred image coming from the eye with the refractive error. And it would, this shutting down is through simply ignoring the input from this eye. It's not that the retina stops getting stimulated. The retina is stimulated. The visual cortex is simply shutting down the pathway that gets the signal from the eye to the visual cortex. And this is what amblyopia is. And although it is possible to get amblyopia with anisometropia of little as 1 diopter, it usually takes more than 1 diopter of anisometropia to get amblyopia. And it's usually a plus error. A minus error or a myopic error does not lead to amblyopia. So amblyopia happens when you have an eye that is apparently fine, it's normal looking eye, it just does not see. It does not see in this case because there was anisometropia, a difference in refractive error between the two eyes, leading to the visual cortex inhibiting the signals from the blurry eye. So the pathway is inhibited and this eye would slowly start losing its vision, which is called amblyopia. And because this amblyopia is because of anisometropia, this type of amblyopia is called anisometropic amblyopia. Let's recap what we have discussed so far with regards to anisometropia and amblyopia. Let's define amblyopia. And amblyopia is gradual and slow cortical inhibition in response to blurred image resulting in poor vision in the affected eye. Anisometropia implies a difference of refractive error of 1 diopter or more between the two eyes. And anisometropia can lead to amblyopia. It generally does not affect myopes simply because myopes are caught early because accommodation cannot fix the refractive error. Thus, they wear glasses, thus good vision, even if it's anisometropia, because both eyes would produce equal clarity of vision once spectacles are provided or their error is corrected by other means, there would be no amblyopia. Hypermetropes can suffer from amblyopia because of anisometropia simply because in spite of the fact that they can overcome their refractive error by the use of their accommodation, the accommodative effort or amplitude of accommodation will only work so as far as to correct the vision in the eye with the less amount of refractive error, because the process of accommodation will stop once one of the eyes is generating a clear image, and that would be the eye with the less amount of refractive error, because if the accommodation increases anymore, it would actually start producing a blurred image in an eye which was generating a clear image before. So accommodation will only work for the eye that has the less amount of refractive error in terms of magnitude of refractive error. The eye with the greater amount of hypermetropia would still generate a blurred image, and that eye would become amblyopic over time. So it develops in children. It only develops in children where the visual system is still in development and malleable between 9 and 12 years of age, closer to 9 as compared to 12, but let's keep it in a sort of a range between 9 and 12. And it takes months to years to develop. It will not develop overnight. So it does take a little bit of time. Anisometropia that occurs in adult maybe because of trauma or surgery or other reason does not result in amblyopia simply because their visual system is fully developed. So how do we overcome or manage amblyopia? Well, the idea is to start off, and it works best if the visual system is still developing, i.e. your child is still between 9 and 12 years of age. If it is more than 12, it's very difficult. Anything younger than 12, and better to be younger than 9, it works better, relatively better. So what we need to do is two things. We need to clear this image up And number two, we need to kickstart this pathway that has stopped. The first step is rather easy. All we need is an appropriate correction, and that would clear this image up. Now we need to restart the pathway that was shut down. And this is the more difficult part, because in order to do this, we need to convince the visual cortex that this image is now good. Remember, it had shut this path down because it was getting a blurred image, and now it is just shut down because it doesn't know that the image is correct. It's like a shop that shut down because it was getting no customers, and unless somebody comes and sees that customers are coming back, the shop would be shut down. So we need some way for this visual cortex to realize that this eye is now getting a clear image. And we do that by blocking the signal received from the good eye. So what we do is we patch the good eye. That's literally what we do. Apply a patch in front of the good eye so that the visual signal from the good eye, the eye that had good vision from the beginning, is not able to send any impulse back to the visual cortex. So the visual cortex is now forced to re-examine what sort of an image is coming from the other previously amblyopic eye, the eye with the refractive error or the greater refractive error. And over time, if done meticulously, and you need very cooperative parents and even a more cooperative child, because the minute you cover the good eye, the visual pathway is not going to accept this image in a day or 2 days or 3 days. It takes time, a lot of time, 30 days, 60 days, 90 days. Any measurable improvement usually takes at least 30 days, sometimes even longer maybe. So you need to convince the parents, and even more important, the child, hey, use the eye through which you really can't see much for a given amount of the day so that your visual system can accept it. And if you say this to a child, he wouldn't accept it because he won't understand. So you need to explain to the parents, we need to cover the good eye so that the brain starts accepting the image from the eye that was previously not generating a good image because of a refractive error. We have cleared the refractive error, produced a good image. Now we need to kickstart the pathway. And this process over time will, if done at an appropriate age, i.e. between 9 and 12 years, is very successful at kickstarting this pathway. And then once both of the eyes have equal visual acuity, you can slowly sort of remove the patching, the process of patching, so that the patient can look through both eyes. Let's do management recap of anisometropic amblyopia, and it can be successfully managed if it is detected early. If it's detected beyond 9 to 12 years of age, it becomes difficult simply because the visual system has sort of established itself and is not as malleable as before. You need to have cooperative parents and children. Parents have to be patient and persistent and constantly encourage the child to patch and keep an eye on the child during the period of patching or the time of patching to make sure that the patch remains on the eye and the child uses the amblyopic eye to see so that the eye can exercise or train. The technique is to fully correct the patient or the child doing cycloplegic refraction. Remember, cycloplegic refraction here is a must to determine the exact amount of refractive error, because accommodation is what is basically the main culprit here. So you need to sort of neutralize accommodation. All these are latent hypermetropes, and unless you do cycloplegic refraction, the exact refractive error can't be figured out. Then we patch the good eye or the seeing eye so that the amblyopic eye is the only eye that the child is using. And since we have corrected this eye now with spectacles, the image on the retina is clear. We just need to kickstart the pathway, and that is by patching. And the most common method is between 2 to 5 hours a day for 5 days a week. 5 days a week, simply we don't want the eye behind the patch to become amblyopic because the child is in a developmental age. So we fix one eye, we don't want the other eye becoming amblyopic. So we allow the child to use both eyes over the weekend or any 2 days of the week. And as I said, this is a very challenging situation, and the results are usually visible after 30 days. And the initial results might be so insignificant so as to be very discouraging for both of the parents, especially for the parents. The child would really not know at this age. But you need to keep on encouraging them that, yeah, things are improving and they can and will improve further if you just give it more time and patience and perseverance and keep on doing it like you are advised to. Various types of patches. You design funny patterns on them so that the child is happy. This is the last thing, I promise you, this is the last thing. And these are WHO standards of vision. It's not who, mind it, it's WHO, World Health Organization. And these are basically used in legal context as well as context of qualifying the vision that the patient is presenting with. So normal vision is between 666 to 618. Impairment is between 618 to 660. Severe impairment is between 660 to 360. Blindness is less than 360 to no perception of light. Blindness is prevalent in Pakistan and India to an extent of 0.2%. These statistics are basically taken from South Asia, so they are applicable to both Pakistan and India. These are answers with explanation. I'm not going to talk over them. There are explanations built in. If you still feel like we need to talk about them, we can do a face-to-face, or you can, ask questions in the regular places, WhatsApp group, which is the easiest place to ask questions, actually. So here comes the answers. Thank you very much for paying attention. If you have questions regarding any of the things that we discussed, including the prescriptions that are coming up, the answers to the prescriptions that are coming up, you know where to ask. Thank you very much.